Recording in progress.
A very good evening, everyone. And today we are here with our next Peto Vision with Dr. Bhaskar Pal as our convener. We are going to be covering today fetal growth restriction and placental abnormalities. We are really delighted to extend this invitation to all of you in our third episode. As we know, fetal growth restriction is crucial to address in any country because it does lead to a lot of complications and it is serious for both mother and baby. By focusing today on FGR, we can improve our prenatal care, reduce the risk of stillbirths, and enhance the long term health outcomes of the affected fetuses. Today's program is specially curated to make cover all problems related to fetal growth restriction, oligohydramnios, placental abnormalities, late onset anomalies, and we have a very interesting panel in our next session. As we say that education is one of the most powerful weapon which can change the world. With these thoughts in mind, let us begin our today's program. For this, our first session, I would like to invite Dr. Chanchal and Dr. Vanna Bansal. Before that, I would also request our convener, Dr. Bhaskar Pal, who is the mastermind behind these webinars, to welcome and say a few words about the program series. Dr. Bhaskar Pal is a senior consultant of Apollo Multispeciality Hospital, Kolkata. He is a very active chair of AICC RCOG, also being the chair of Endoscopy Committee of Suffolk, Foxy representative to Suffolk, past president of Bengal OBGYN Society, and past vice president of Foxy. Welcome, sir.
Thank you very much, Niharika. I keep saying the same things every day. I think, as I say, that COVID has left many nasty memories, but one thing it's given us is the virtual platform. And I think that we've now restarted conferences. We go to conferences, and that's great way of meeting people. But I think for education at the present moment, apart from focused and skill transfer sessions, the webinars are more valuable than face-to-face meetings. So it's great because of that. We are running this focused webinar series, and I learn a lot from fetal medicine because I'm not a fetal medicine specialist, and it gives me great insight into things. And I'm really thankful to all the faculties for taking their time out for sharing their expertise with the audience. So I hope that today also would be a fruitful evening of learning. And I take this opportunity to thank Dr. Chanchal, Dr. Vandana Bansal, our chairpersons, Dr. Pooja Lodha, Dr. Kanchan Mukherjee, and Dr. Vijay Balakrishnan, our speakers, Dr. Devashmita Mondal, our moderator, and Dr. Malti Prasad, Dr. Shankar De, Dr. Sujit Konkar, Dr. Megha Kamlapurkar, Dr. Venita Singh, Dr. Anana Basu, and Dr. Josna Rani Panigrahi as our panelists. So we have faculty from all over India, everybody renowned in their field of fetal medicine. Nobody here has faculty who doesn't do fetal medicine. And it is easy to dream of something or plan something, but it's extremely difficult to execute unless you have a team. I'm really thankful to Dr. Aparna Sharma, Dr. Sita Ramamurthy, Dr. Niharika Malhotra, Dr. Prasanna Roy, and Dr. Sama Devdasan, who take turns to devise this program, the content, contacting everybody, and executing it flawlessly. I would also take this opportunity to thank Lifestyle M5 for their unwavering support to these webinars and to Conference International for the publicity and the platform. Thank you very much. Back to you, Niharika. I hope that there will be a very, very enriching experience this evening.
Thank you so much, sir. And we would now like to begin our session. For the first session, I would invite our chairperson, Dr. Chanchal. Dr. Chanchal is the lead consultant, fetal medicine at Madhukar Rainbow Children's Hospital, Birthright, New Delhi. She's also been the executive member and central committee of Society of Fetal Medicine, editorial board of Journal of Fetal Medicine, and also been the current member representative of International Representative Committee, RCOG North. Grateful, ma'am, for you to accept our invite. Our next chairperson for today's session is Dr. Vanna Bansal. Dr. Vanna Bansal is Professor OBGYN and Head of Ultrasound Department at Wadia Maternity and State GS Medical College, Mumbai. She is Director Fetal Medicine Center at Surya Mother and Child Hospital, Mumbai. Also, she has runs multiple fellowship programs in fetal medicine, ICOG course coordinator, and for a certified course in fetal medicine and examiner for Part 3 MRCOG exam. Thank you, ma'am, for being with us today, and we would invite the chairpersons to please introduce our speakers and begin this session.
A very good afternoon to all. I think it's a great initiative by Dr. Bhaskar Pal and Sita for arranging this feto vision. The word itself says it's a vision for the fetus, for the obstetrician. So these all topics have been very nicely curated so that the obstetrician learn a lot from this, and the best of best faculties have been called. So I would like to introduce Dr. Pooja Lodha, a very nice friend of mine. She is the director of Kangaroo Cradle, the Fetal Care Clinic, State of Art Fetal Medicine Center in Pune. And she is a lead consultant there in fetal medicine and fetal therapy, as well as in Ruby Hall Clinic and Bharati Vidya Medical College. She is also Southeast Asia Ambassador for GLOWM International FIGO platform and university recognized trainer and thesis guide for fellowship in maternal fetal medicine at Bharatiya
Thank
Vidya.
you so much,
So I
ma'am. Thank
think,
you for the kind
I don't want to take time off from your lecture, and we would want to
Yes.
listen to you, please. Thank you.
Thank you so much, ma'am, for the kind introduction. It's my privilege to speak when you and Dr. Chanchal ma'am are chairpersons. And like you said, feto vision is vision for the fetus and the obstetrician. And when we have Bhaskar Pal sir as the president of FOXY, we will have vision for the FOCTRI and V for victory. So on this note, can I please share my presentation? Are the slides visible?
Yes, yes.
Okay. So it seems to be a very, very simple topic, and simpler the topic, the more difficult it is to make the presentation and express it. But like I always feel, when things go wrong and we go back to introspect where we could have changed something, it's usually the basics. So although Bijoy is here, and he would agree that no algorithm for fetal growth restriction relies alone on amniotic fluid to take a decision for delivery or for monitoring, but amniotic fluid, either too less or too more, is something that we face in the OPD almost every single day. And we need to find out the cause and really see how the prognosis of the pregnancy is going to go, whether it's going to be modifiable, whether it's going to help in decision making and change our antenatal course or not. So I will only take you through the practical aspects and probably finish before time and keep some time for discussion. So amniotic fluid is a clear yellowish bacteriostatic liquid. Now I put this up because it is not bactericidal, it is bacteriostatic, and this is the reason why all the situations where we can have chronic, subacute or acute chorioamnionitis, we need to remember that although amniotic fluid does fight infection in situations, it's not bactericidal, it is only bacteriostatic. It stops the growth, but it does not kill the alive bacteria that are already present in the amniotic fluid. So it's a clear yellowish bacteriostatic fluid that surrounds and protects the fetus in the amniotic sac. So we can see that if there is reduced amniotic fluid, it is known as oligohydramnios, and if the amniotic fluid is increased, it is known as polyhydramnios. What are the two basic reasons why there would be oligohydramnios? Either the fluid is being normally formed but leaking out, as in rupture of membranes, or the production itself is reduced. So for whatever reasons, the amniotic fluid is not being produced enough, and these are the two major reasons of oligohydramnios. Similarly, what causes polyhydramnios is if there is a decreased swallowing. So the whole cycle of the kidneys producing urine, forming amniotic fluid and being swallowed by the fetus is what maintains a normal amniotic fluid in the pregnancy. And if the fetus for any reason is unable to swallow the amniotic fluid, or if the production is excess for some reason, these are the two causes of polyhydramnios. Now this is a very basic overview of both the abnormalities of amniotic fluid, and we'll go through each of them. Now, amniotic fluid is extremely important for the fetus, and these are the functions mentioned here. we take them for granted. We've studied them during our PG days, but it's extremely important because it creates a physical space for movement of the fetus, which is extremely important for normal musculoskeletal development of the baby. It permits fetal swallowing, and therefore it's important to maintain the patency of the gastrointestinal tract and development of and also fetal breathing. So, which in turn helps in lung development. It protects against umbilical cord compression. We are aware that fetuses which have oligo or anhydramnios, or where already a rupture of membrane has happened and she is in labor, are at a higher risk for having CTG abnormalities, cord compression. It's because there is no buffering, there is no cushioning around the baby, and therefore amniotic fluid is extremely important for that as well. Prevention of adhesion of the fetus from the amniotic sac. We are aware of the amniotic bands and the various abnormalities where there are amniotic sac rupture sequences, which in turn cause a lot of bands. So that's where again there is the abnormality of amniotic fluid that causes these. It has bacteriostatic properties and can fight infection up to a particular limit, as we discussed. It maintains fetal temperature and absorbs shock. This is very important. During labor, when there is dilatation of cervix, the presence of normal amount of amniotic fluid actually forms a very good hydrostatic wedge, so as to cause compression on the cervix and help in its dilatation. And therefore, even during labor, amniotic fluid is extremely important. During uterine contractions, a normal amniotic fluid with intact membranes prevents interface with placental circulation, and it's less likely to have CTG abnormalities. Now here we see that from 12 weeks, 20 weeks to 30, 34, 36 weeks, all these fetuses are swallowing. So I put this up because even a 12-week fetus starts swallowing, and we need to know the origin of amniotic fluid at various gestational ages to understand what is the pathology of abnormal amniotic fluid at that particular gestational age. So, like for any other thing in fetal medicine, in fact obstetrics, just like there is no one number that is normal. Ki umbilical artery PI of 1 is normal. That's not so. It depends on the gestational age. Similarly, even the amniotic fluid, a fluid of 8 or 9, we could call it reduced for a gestational age of 27 weeks, but the same amniotic fluid of 8 centimeters could really be very well within the normal range near term, and therefore we need to follow normograms as for anything else in fetal medicine, and do not comment on absolute numbers. How do we measure and quantify amniotic fluid? The typical traditional way to do it is the 4-quadrant AFI, where you virtually divide the mother's abdomen into 4 quadrants and take one measurement in each quadrant, add them up. This is the total amniotic fluid index. The normal range grossly is between 5 to 25 centimeters. Oligohydramnios is defined as less than 5 centimeters by this method of measuring AFI, and polyhydramnios more than 25 centimeters. Now, having said that, it doesn't mean that if there is an AFI of 24, you ignore it and say that it is normal. When the range is provided, we need to make sure that we understand that this is only the 5th and the 95th centile, but anything around that number is also significant. For example, if the AFI is 6 or it is 24, you need to mention that the amniotic fluid is on the higher side of normal, and so needs to be checked. Now, we will come to the deepest vertical pool soon as we talk about polyhydramnios. So there are 3 degrees of severities of polyhydramnios. One is mild. The first is mild, where the deepest vertical pool, or a single vertical pool. I don't know where that slide is gone. Okay, it's an oligohydramnios. So an amniotic fluid between 25 and 29 centimeters of AFI is mild polyhydramnios. Between 30 and 35 is moderate, and more than 35, any AFI more than 35 is severe polyhydramnios. Now we need to understand that when you see high amount of amniotic fluid, it's all of these need to be kept in mind to make sure that we diagnose the reason for polyhydramnios. Believe me, oligohydramnios is much easier to tackle because the commonest reason is fetal growth restriction, or very obviously bilateral renal agenesis, or a rupture of membrane. These are the 3 common causes for oligohydramnios, and we'll come to it. But when you see a fetus that is normally growing, or which is actually small or an SGA or an FGR fetus, and there is polyhydramnios, we really get worried. So we don't really like small babies with polyhydramnios, and you need to go through all these factors to really find out if the baby is able to swallow normally and what could be the actual cause for this polyhydramnios. For example, is the bony support normal? So in cases of cleft lip, palate, ergnathia, retrognathia, micrognathia, we do find a level of polyhydramnios which increases eventually with gestational age, and this is because the normal bony support for normal swallowing is lost in such babies. Secondly, if there is a loss of structural integrity, for example, there is tracheoesophageal fistula or there is an esophageal atresia, this leads to abnormal swallowing because the amniotic fluid is not able to pass through the esophagus into the stomach completely, and that again causes polyhydramnios. Now, proper musculature, we are aware that musculoskeletal abnormalities in the baby could also lead to polyhydramnios, and innervation to the tongue, palate, esophagus, oropharynx as seen in neuromuscular disorders. So if any of these are abnormally innervated, we see polyhydramnios because the fetus does not swallow normally. There are brainstem abnormalities like in acrania and severe microcephaly, where the brainstem cannot give a signal to the fetus that you need to swallow now, and that again in turn causes polyhydramnios. And of course, the most important, you need to make sure that the amniotic fluid is present in normal quantity. For example, if you see that she has leaked out all fluid, if the lady's had a rupture of membrane, and you keep searching for a stomach bubble, you may not find it. Doesn't mean the baby has tracheoesophageal fistula or some problem, but it simply means that there is really no normal amount of amniotic fluid around the baby for it to swallow and reach the stomach. So, in spite of so many causes of polyhydramnios, 70% of the polyhydramnios continues to be idiopathic. You never come to know why they are. But the good news is that most of these are mild. Most of these do not increase the morbidity and mortality. And let's come to some workup here on polyhydramnios. So once you see that there is polyhydramnios, the first thing that you do is go back and ask for the maternal blood sugars. This is, it's pretty common to find a scenario where the lady keeps telling us that she does not have GDM and all the blood sugars are normal, yet we find that probably the abdominal circumference is nearing the 90th centile or sometimes even normal, but there is mild polyhydramnios, and eventually after 2 weeks, her glucose tolerance comes out to be impaired. So sometimes it's a retrospective diagnosis. Once the scan says there is polyhydramnios, the lady goes on to have a GDM. So look for maternal diabetes. Now, fetal infection. This is a peculiar situation where you will find a small baby with polyhydramnios. Like I said, it's an ominous sign to find a small baby with polyhydramnios. When you find this combination, you are either looking at a fetal infection or you are looking at a baby which has FGR along with some structural abnormality, probably a tracheoesophageal fistula or a cleft palate or something, and along with that there is an FGR, and therefore you are seeing polyhydramnios despite the baby being small. Then you look for the stomach bubble. So very typically we find reports saying that there is severe polyhydramnios and the stomach bubble looks less distended or could not be visualized, and there we raise a suspicion for the tracheoesophageal fistula or the esophageal atresia. The facial clefts, yes, you go back. So typically when you find polyhydramnios, it's in the 3rd trimester, and when you are doing a growth scan at 3rd trimester, remember every scan is an anomaly scan, because all the things on the screen right now, none of them would be detected if you do not treat your growth scan as an anomaly scan. Once you get a polyhydramnios, go back to the spine, go back to the movements, go back to the cleft, maybe probably just an isolated cleft palate, probably a small mass near the thyroid, something that the baby is not able to, it's preventing the baby from swallowing normally. So treat your 3rd trimester scan also as an anomaly scan to look at the cause for this polyhydramnios. And of course, arthrogryposis, which would not be missed. You will have fixed flexion deformities of the limbs. You will see that the baby is not moving well, and there is polyhydramnios. There could be an obstructing mass, for example, a fetal thyroid goiter that is, obstructing the amniotic fluid from being swallowed normally and causing polyhydramnios. Similarly, there is a situation where there is a paradoxical polyhydramnios in a uretropelvic junction obstruction. So, surprisingly, when we find a unilateral uretropelvic junction obstruction, we see that the contralateral kidney kind of overworks and overcompensates to produce more amount of urine, and that causes polyhydramnios. It's a known phenomena, and after reading this a few years back, I did observe a few, and yes, it does exist. Very uncommon. Anyways. So yes, sacrococcygeal teratoma, because this is a hyperdynamic circulation, it will increase the amount of blood volume and therefore the urine and therefore the amniotic fluid, causing polyhydramnios. Large chorioangiomas for the similar reason will also have polyhydramnios. Now let us see this, something very interesting. This is for all of us who actually report simple unexplained polyhydramnios. So as we are aware, the most difficult thing is to call something isolated. So this is a study where the outcomes of children born out of pregnancies complicated by unexplained polyhydramnios was studied, and it was found that of the neonates born to women with unexplained polyhydramnios, 25% had anomalies postnatally. This is a big number, despite a normal detailed anatomy scan antenatally. And we are not surprised to find that the majority, almost 10% of such babies were found in severe polyhydramnios. In short, when you find a report which says severe polyhydramnios and the baby otherwise looks normal, there is no macrosomia, nothing structurally, the mother's blood sugars are normal, please put in a word of caution saying postnatal assessment is needed, because there could be surprise anomalies postnatally, and almost always, unless proven otherwise, severe polyhydramnios is associated with some morbidity of the fetus or the mother. One example is an immunologically positive mother could have a normally growing baby with unexplained severe polyhydramnios. So I've seen one IUFD in such a situation. So do not ignore an unexplained severe polyhydramnios. Now, of course, treat the cause if it is maternal hyperglycemia. Amnioreduction, the only indication for amnioreduction is if there is such severe polyhydramnios which is causing maternal discomfort or dyspnea, and this is an SFM grade 1C guideline. Almost all such cases will be associated with fetal abnormalities unless we are dealing with a case of TTTS or otherwise. Indomethacin is contraindicated. There are a lot of studies that come up with 20 and 25 cases saying that we've given indomethacin and it improves unexplained idiopathic polyhydramnios. But mind well, we'll come to the next slide where the fetal renal function deteriorates in the neonatal period if indomethacin is given to treat or to manage unexplained polyhydramnios antenatally. So, preterm infants, especially exposed to indomethacin in utero, have been shown to reduce neonatal urine output and elevated serum creatinine concentrations. There is an increased risk of neonatal morbidities, intraventricular hemorrhage, periventricular leukomalacia, and necrotizing enterocolitis in such babies that were treated with indomethacin. So, therefore, a meta-analysis here that says indomethacin is absolutely not recommended for reducing amniotic fluid in fetuses with polyhydramnios as the risks are more than the benefits. Antenatal fetal surveillance is not required for isolated mild idiopathic polyhydramnios. You can just manage them like other women. Isolated mild idiopathic polyhydramnios, you can wait for spontaneous labor at term. There are some obstetricians who feel that these women are more likely to have cord prolapse and they may go into prom, but evidence says that if it is mild, then usually the outcomes are unaltered in such situations. But women with severe polyhydramnios, for the reasons that we just saw, should deliver at a tertiary care center because of the significant possibility that the fetal anomalies may be present postnatally and may come up as a surprise. So this is one of the latest studies that I found where idiopathic polyhydramnios, they did a review and meta-analysis, and they found that all these complications were slightly increased in women with mild idiopathic polyhydramnios. But the catch here is that they said that the significance was not the odds, the p-value was not significant. So although in absolute numbers we see that all the risks were increased, but no, this is not a reason to just take her up for a cesarean birth at 37 weeks. Now we come to oligohydramnios. This is a situation where there is an abnormally decreased amount of amniotic fluid, and instead of doing the 4-quadrant AFI that we just saw for polyhydramnios, it has been found by Cochrane, ACOG, and many other guidelines henceforth, which I will quote soon, that the single deepest vertical pocket is much more beneficial to measure in cases of polyhydramnios as compared to the 4-quadrant AFI. So imagine a situation where you have a report from your radiologist or fetal medicine specialist that says that the AFI is 3.5. That could be really scary, and it could trigger off a delivery or a cesarean section even at 34, 33 weeks when everything else is looking fine. And which is why a lot of studies have now been done which say that do not rely on the 4-quadrant AFI for oligohydramnios to decide delivery, but wait for a deepest vertical pool to go less than 2 centimeter. So what is a deepest vertical pool? You find a single largest vertical pool in the whole maternal abdomen and you measure that. If it is more than 2 centimeters, you are good to go ahead. So also probably there's a whole panel on FGR, and we will see that amniotic fluid is one of the adjuvants to take decision making. So alone an AFI of 3 centimeter or 4 centimeter should not be a criteria to jump to a conclusion where we are delivering this baby. Of course, in twins, we do measure only deepest vertical pools, and less than 2 centimeters is oligohydramnios. The criteria is the same for even a singleton. When there is no measurable pocket of amniotic fluid, this is known as an unhydramnios. Now, Cochrane usually does not come to any conclusion, but in this situation, it has clearly mentioned that amongst 4-quadrant AFI or a deepest vertical pool, measuring the deepest vertical pool is a better choice, since the use of 4-quadrant AFI over-diagnoses oligohydramnios, and the rate of induction of labor increases without improvement in peripartum outcomes in the mother as well as the baby. So the outcomes have not improved, but the rate of induction of labor and in fact cesarean birth in most studies has increased if you count on the 4-quadrant AFI for oligohydramnios. Now this could be a little tricky, because we would feel then how do we report AFI? Do we do a single vertical pool or do we do a 4-quadrant? Now what I usually have started doing, because all these years the obstetricians are very used to getting the 4-quadrant AFI. So I continue to measure the 4-quadrant AFI, but when a situation arises, for example, the 4-quadrant AFI measures 3.5 centimeters, but the deepest vertical pool is more than 2 centimeter, weekly follow-up is recommended. So that's when you bring in your deepest vertical pool, and probably this is a transition phase when everybody is not very used to a single vertical, deepest vertical pool. There would be a time when probably we would just use DVP to define all outcomes in oligo and polyhydramnios. So causes for oligohydramnios depend on the gestational age. Now, if there is bilateral renal agenesis, there is no urine being formed, the baby is not passing urine, there will be severe oligohydramnios, and this would present probably after the first trimester, because the source of amniotic fluid up to 12 weeks is not majorly by the, it's not majorly by the fetal kidneys, but it is by the lung exudates, by the skin exudate, and therefore you will still find some amount of amniotic fluid around the baby, even in cases of bilateral renal agenesis. But typically you will find that while eyeballing the baby during NT scan, you will find it is slightly reduced. Please call her back, and the best thing is to document kidneys at 12 weeks. So if you document kidneys at 12 weeks, you've ruled out bilateral renal agenesis. Then, of course, PROM, one of the commonest reasons. We go back to our basics. When we see reduced amniotic fluid, we start looking for the kidneys, we start looking for the Dopplers. Probably just ask a simple question to the mother: has she had a sudden leakage of amniotic fluid? And we really indeed forget to ask that, and that's the commonest reason for a PROM. Another very common scenario, actually the commonest scenario, is when you find that there is fetal growth restriction. So what is amniotic fluid? It's the urine of the baby. Good amount of fetal blood volume, good amount of urine formation, good amount of amniotic fluid. Therefore, small babies, reduced blood volume, reduced filtration and urine formation, and reduced amniotic fluid. So this typically means that a baby that has started to have fetal growth restriction will eventually at some point in time show a reduced amniotic fluid and or abnormal Dopplers, so on and so forth. So these are the causes for oligohydramnios, the commonest ones mentioned. We've discussed the maternal ones. Now the fetal ones are, yes, when the baby itself is genetically chromosomally abnormal, there is growth restriction, there has been a demise, or in post-term pregnancies, the amniotic fluid starts to reduce even physiologically and ruptured membranes. Maternal causes are uteroplacental insufficiency, preeclampsia, chronic diabetes, pre-gestational hyperglycemia will cause a small baby with an oligohydramnios due to vasculopathy. Placental abruption, TTTS, will have reduced amniotic fluid in the smaller baby. So why is amniotic fluid so important? And when the oligohydramnios or the unhydramnios is developing is extremely important. If the lady leaks out amniotic fluid and has a rupture of membranes after 26 weeks, we are really not as much worried as we are if she leaks out between 16 and 26 weeks of gestational age. A lot of times we find that she is leaked at 22 weeks, but she is not going into labor, the cervix is nice and long, not effaced, she doesn't have chorioamnionitis, we continue the pregnancy, the baby probably grows in weight as well because there is no other factor restricting the fetal weight. But as soon as the baby goes to the NICU, it requires very high ventilatory support, and this is because the main canalicular phase of fetal lung development happens between 16 and 26 weeks. This is when the respiratory bronchioles are multiplying in size, and if you do not have enough amniotic fluid for the baby to swallow and for the lung development between 16 and 26 weeks, it causes pulmonary hypoplasia, and this is the reason for the morbidity and the mortality when there is an early rupture of membranes. So what are the strategies for treatment for isolated unexplained oligohydramnios? Oral hydration therapy really works well, and the best thing is there is no harm. So no risk to the mother and the baby. It is cheap, easily available. I explained to them that you need to drink 4 liters of water in a day, of which 2 liters need to be within 2 hours. So more amount of oral fluid within 2 hours or within a less stipulated amount of time causes a faster osmosis and the amniotic fluid into the sac, and this is one of the proven strategies to work for isolated unexplained oligohydramnios. Now intravenous hydration therapy, yes, it does need admission. 2 liters of hypotonic solution IV, the risk of maternal fluid overload is there. Hydration reduces maternal plasma osmolarity and improves placental perfusion. So the amnio infusion, obstetricians are extremely fond of this procedure, and unfortunately their demand of amnio infusion is reducing by the day. There is no indication for amnio infusion unless the lady is in labor, she is in periphery, there is no provision for a cesarean birth, she has persistent variable decelerations, she is leaked out all fluid, and you need to do an amnio infusion to buy time, to prevent cord occlusion, and during uterine contractions you need to provide a cushion around the baby. This is the only very hypothetical indication for amnio infusion. For any other reasons like renal agenesis, FGR, or rupture of membranes, when the lady is not in labor and not going to deliver, please do not do amnio infusion and do not encourage amnio infusion. These are the complications of amnio infusion. You can see they are really fatal and not of great help in any way. So this is a simple flow chart for oligohydramnios, very simplified. When you have an amniotic fluid index of less than 5 centimeters or a deepest vertical pool of less than 2 between 28 and 40 weeks, you assess for rupture of membranes, look for Dopplers, look for the baby's size, Ask for history of PIH or pre-pregnancy hyperglycemia or fetal compromise due to any reason. If yes, you know the answer. If no, look at the anomalies. Are any anomalies detected that are causing this oligohydramnios? For example, multicystic kidneys, bilaterally polycystic kidneys, bilateral renal agenesis. Then, depending on the anomaly and the presentation, decide on the termination or prognosticate the situation. If there are no maternal factors, no fetal factors, no anomalies detected, in fact, this is actually an idiopathic unexplained oligo. Please encourage oral hydration more than IV hydration. Now, is the AFI more than 8? Reassess the situation. If not, please keep following up every 10 to 14 days to see what happens. So, isolated oligohydramnios is not associated with adverse perinatal outcomes. This is a study where they analyzed a huge number of women, 15,000, over 15,000 women, and they found that pregnancies with isolated oligohydramnios in the second trimester had a similar perinatal outcome as compared to women with normal amniotic fluid. The only difference was statistically significant cesarean birth in these women. This is the last slide, very clinical points here. Measure AFI only after 16 weeks. In case you find while eyeballing that during the NT scan or 12 weeks, you find that the amniotic fluid is reduced for gestational age. Please mention please quantify the deepest vertical pool measure so and so. Do not say it is slightly reduced or slightly increased because you will not remember the next time you're scanning this lady, you may not remember how much amniotic fluid you saw last time, and you will not be able to see the interval growth of the amniotic fluid between two scans. So never mention vague terms like slightly reduced, slightly increased. Always mention a number. When you suspect polyhydramnios, 4-quadrant AFI works better. When you're suspecting oligohydramnios, please place your decision making on single deepest vertical pool along with other factors of the mother and the baby. You look for the maternal disease, fetal structural abnormalities with abnormal amount of amniotic fluid. Higher the polyhydramnios, more are the chances of underlying fetal abnormalities. Isolated oligo or polyhydramnios with no other factors in the mother of the baby usually has an excellent prognosis. Thank you so much for patiently listening.
Thank you, Dr. Pooja, for such an excellent lecture on oligo and poly. So, a lot of things that you have put forth, which are very important, is that for polyhydramnios, indomethacin is not a good drug. So, which has to be taken, that you don't give indomethacin unless it is very carefully monitored. For oligo, as you said, how I look at it is pre-renal, renal, and post-renal. So your pre-renal are all your maternal disease, placental insufficiency. Renal are all the renal disorders and obstruction. And post-renal is a PROM. So kind of that. And plus what you said that largest vertical pocket should be used now because it reduces the number of inductions, the number of sections being done for oligohydramnios. And I think in IUGR, Liker is not mentioned for the management of FGR, and only Dopplers are what we look at and the CTGs. That will come to next, but excellent lecture to cover up both the oligo and the polyhydramnios. I give over to Chanchal for introducing the next speaker.
Good evening, everyone. After that excellent lecture, we move on to the next part. So, Dr. Kanchan Mukherjee, I think most of us know him very well. He is a consultant and fetal medicine specialist at Apollo, Kolkata. He is the president of Society of Fetal Medicine Bengal chapter. He's faculty for various national and international conferences and has several papers published in peer-reviewed journals. Welcome, sir.
Thank you, chairpersons. Let me just share my screen. And thank you, Dr. Bhaskar Pal, Sita, and those who gave me this opportunity to present in front of you. Yes. Yeah. Can you see my screen now?
Yes, we can see it, sir. Yeah, it's visible.
Yeah. Okay then. As they say, if baby is a fruit, then placenta is the tree. So if we have to have a good fruit, then we have to have a good placenta. And in scientific terms, I think placenta should be seen as an all-in-one organ which serves as a respiratory, excretory, and endocrine organ throughout the pregnancy, providing nutrition and immune support for the developing fetus. Now, it it can also result in pregnancy-induced hypertension, fetal growth restriction, and fetal loss with its dysfunction and the abnormalities, particularly the likes of placental abruption or abnormal placentations like placenta accreta spectrum, can have catastrophic effects. So it is all the more important that we study the placenta as carefully as we study the baby. Now, gone are the days of Granum grading of placenta, which was brought in the 1970s, where they used to correlate the fetal maturity with placental changes with a degree of calcification. It was highly subjective with not much of clinical significance proven in the recent times. So what are the different types of placental abnormalities? Well, they can be morphological, like bilobed, succenturiate lobe, circumvalent placenta, placentomegaly, or placental mesenchymal disorders, or they can be abnormal in terms of their location, like placenta previa. Then we have a group of abnormalities called placental abruption, where the bleed can be retroplacental or subchorionic or can even be preplacental. Then comes the big player, that is abnormalities in placentation, that is placenta accreta, increta, and paracreta. We also have the placental tumors, which can be subdivided into two broad groups like trophoblastic and non-trophoblastic. We all know about trophoblastic. Now, among the non-trophoblastic tumors, we have chorioangioma, teratoma, and metastasis. It's not possible to cover everything in 15-20 minutes, but I will try and cover the major ones. Bilobe placenta, this is a gross pathological specimen at term where the placenta is clearly divided into two lobes, and you can see the cord is arising from somewhere at the center. Then the subcenturiate placental lobe at 34 weeks, where you can see the cord arising from the membranes. It is not always possible to pick these placental abnormalities on ultrasonography antenatally. Then we have the next group, the circumvallate placenta. This is an example of 37-week circumvallate placenta, where you can see the placental cord insertion is towards the periphery, and you can see a rolled up margin there, which may appear as a rack on ultrasonography. Placentomegaly, it's difficult to say when do you call placentomegaly in terms of thickness, but most of the literature says if it is anterior placenta, go by the rule of 4 centimeter. If it is posterior, go by 3.4. So if you remember the ballpark figure of 4 centimeter placental thickness, and if it goes beyond, then you can call them placentomegaly. And immediately you should think of the causes, mostly maternal diabetes, maternal infection like toxoplasma, rubella, and many other infections. Fetal macrosomia syndromes like Beckwith-Whitman syndrome can also cause placentomegaly, and obviously we have fetal hydrops in this group. So the moment you see placentomegaly, you have to think about a series of possibilities. Placental mesenchymal dysplasia is not that common. where the placenta is enlarged with cystic grape-like components, and that can resemble partial molar pregnancy, because here also you can have a viable fetus. 1/3 of these cases would be associated with BWS. So again, there are differential diagnoses, and it can be an important clue to a bigger problem. Now, placenta previa, as I mentioned, this is an abnormality in terms of the placental location. Now, we keep on using the terminology interchangeably, placenta previa and low-lying placenta. They are not so uncommon. It is about 1 in 200 at term. But if you remember the 2 centimeter rule given by AIUM currently, then you would not go wrong. If the placental leading edge is beyond 2 centimeter from the internal os, it is normal. If it is within 2 centimeter, it is low-lying placenta. If it is covering the internal os, it is previa. It is simple these days. No more placental grades, placenta previa grades like 1 to 4, and no more partial or marginal. So what are the risk factors for a low-lying placenta? Well, they are cesarean delivery, assisted reproduction, and maternal smoking. Placental abruption, as I mentioned, can be retroplacental, subchorionic, or preplacental even. It has a poor diagnostic sensitivity on ultrasound, and it is an obstetric emergency. So do not waste your time asking for a scan to make the diagnosis. Apply your clinical acumen and ask for a CTG, and that should be enough to make a diagnosis of placental abruption. Ultrasonography is not good for making placental abruption diagnosis. Now, placental accreta is a spectrum disorder. It was not that common. I mean, UCOS data says, UK obstetric surveillance sample data says it is about 1.7 per 10,000 women. But the moment you have the combination of previous cesarean section and placenta previa, see, the number is 577 per 10,000. It can be that high. Now, this is a histopathological description, which goes like abnormal adherence of the afterbirth in whole or in parts of the underlying uterine wall, in the partial or complete absence of extra. Then you have 3 different divisions like creta or adherenta, where the villi adhere superficially to the myometrium. In creta, where the villi penetrate deeply into the myometrium, but serosa remains intact, and parcreta, where villus tissue perforates the uterine wall and may invade the surrounding pelvic organs. Now, terminology issues. The nomenclature has been nothing less than a scientific chaos. It came as a description like morbidly adherent placenta, coined by a Scottish physician in 1885, where for retained cotyledons, they used to give the mother argot alkaloids, opiates, or even brandy. Then the terminology started rolling up in the literature like placental adhesive disorders, pernicious placenta, but all these names lacked diagnostic accuracy. It was very subjective. Then this working group was formed in the Europe, that's European Working Group, who said the description should be abnormally invasive placenta. But that encompasses only the increta and parcreta. However, that raises awareness for the end of the spectrum. Within a year, that was back in 2017, the European Working Group realized that they should form a society, international society, which they did, and named it as placenta accreta spectrum. Within 2 years, FIGO accepted that terminology, but with slight modifications. Grade 1, 2, 3, like placenta accreta, increta, and parcreta, but 3 was then subdivided into 3A, B, C, depending on depending on the degree of invasion. If uterine serosa was invaded, it was 3A. If bladder, 3B. And if it was beyond, then it was 3C. So there goes the terminology issues. So what are the major risk factors? Well, it has to be placenta previa, previous cesarean section, and it's a cumulative risk. See, if there has been one previous cesarean section, the risk is 3%. With 3 cesarean section, it is 40%. If it is 5 cesarean section, it is 67%. So more the number of cesarean sections, more is the risk for adhesive placenta accreta spectrum, I must say. Well, the history of accreta in a previous pregnancy works as another risk factor, and any previous uterine surgery, including repeated endometrial curettage, can also serve as a risk factor for this PAS. So how do we screen for placenta previa or accreta? Well, during mid-pregnancy, we do a fetal anomaly scan and look at the placental edge, how far it is from the internal os. Don't hesitate to use transvaginal scan if necessary, and do not make a diagnosis of placenta previa in less than 16 weeks gestation. If it is low-lying, then follow-up ultrasonography, including a TVS, is recommended at 32 weeks, as migration happens in about 90% cases. Now, there is a lot of myth about using TVS in low-lying placenta, but you should not. It is a safe method, as clearly said by RCOG Green Top Guideline 27, that it is superior to transabdominal and transperineal approaches, particularly useful in posterior placenta, because if you are doing a transabdominal scan, then head might be on the way, hampering the vision. Additional TVS at 32 or even 36 weeks to inform discussion about delivery is necessary. It also allows good cervical length assessment. So do not hesitate to do a transvaginal scan. It does not herald torrential bleeding. Imaging modalities for placental assessment, what are those? We keep on saying MRI, 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 but it is the ultrasonography with Doppler that is the modality of choice. MRI only when ultrasonography findings are equivocal, because the soft tissue contrast is better with MRI. Now, CT scan has very limited role in obstetrics unless there is a trauma and you need to evaluate metastasis during pregnancy. Now, how good is ultrasonography? It has to be, as I said, 2D scan plus Dopplers. As you can see, the sensitivity with grayscale only is about 50 to 87%, but the moment you add color Doppler, sensitivity goes very high up. However, the specificities are pretty much the same. As RCOG says, the different signs that you should look for on 2D grayscale is loss of clear zone, abnormal placental lacunae, bladder wall interruption, myometrial thinning, placental bulge through the serosa, and focal exophytic mass. So these are the signs that you should look for on 2D scanning. And 2D color Dopplers should actually be added, and you should look for uterovesical hypervascularity, subplacental hypervascularity, bridging vessels right through the bladder, and placental lacunae. All these are not so difficult to obtain as long as you know what you are looking for. Those who are doing cesarean sections, they may be familiar with these pictures. They are horrendous when you are in the OT. You can see a bulge, as I mentioned. You can see bulge coming from the lateral wall. It can be a complete rupture, and so on and so forth. So what is the clear zone that we keep talking about? Basically, clear zone is the uteroplacental interface where you can see this hypoechoic zone all the way up and down. Now, if there is loss or irregularity of this hypoechoic plane in the myometrium underneath the placental bed, then you suspect adherent placenta. What are the abnormal placental lacunae? Now, this is an example where that clear interface is not so well visible. Instead, you are seeing a lot of hypoechoic lakes. Now, if you apply color when the placenta is adherent, you see the color all over the place. I'm just running that video once more. See. So what are the four major points to look for on ultrasonography? You have to look for abnormal adherence or invasion to myometrium. You should look for hypervascularity, if there is thin or absent endometrium, and if there is invasion to other structures, you should suspect placenta accreta spectrum. Tips for good scanning: you should have a full bladder, particularly towards the term. Avoid excessive probe pressure. Don't hesitate to use TVS if necessary, and also go transverse up to the cervix with your color Doppler, because obstetrician needs to know if he or she has to do a cesarean hysterectomy and they have to do a colpotomy. They want to know the extent of vascularization, so it is all the more important. How do you report the scan? It's not enough to say placenta accreta, increta, or partreta. You are not trying to predict the histology. Instead, you want to give them a description. So be descriptive, something like abnormal lacunae with high velocity feeder vessels, or undetectable myometrium, no clear zone, placental bulge with location, bridging vessels if there is any, linking the placenta to bladder. So all these description will do better for the obstetrician concerned. To finish with, I want to say a few words about scar pregnancy. Beware, because this might be a precursor of one of the different grades of placenta accreta spectrum. Scar pregnancy, when managed conservatively with positive fetal heart activity, can actually be later on a severe placental accreta spectrum disorder, and we still do not know the natural history of these. So be on the high index of suspicion for these. So it is possible to predict the scar pregnancy in first trimester, as I've just described. Now, I want to finish with these take-home messages: that it is important to diagnose placental abnormalities. You should know the normal appearance of uteroplacental interface, and then look for abnormal signs, as I have just explained. Two primary questions. One is it placenta previa? And has there been any cesarean section or any uterine surgery? These two plus are clincher, basically. These two primary questions. And beware of scar pregnancy. Thank you.
Thank you for that excellent lecture, Dr. Kanchan. I think you've covered all the points, and all of us are increasingly seeing cesarean scarring topics. And yes, there may be an occasional patient who may want to continue with expected management. And many times you may not have seen, the patient may not have had a previous viability scan. So whenever previous repeated DNCs, previous cesarean, and a low-lying placenta, I think we need to pay more attention and store these images, because it can be catastrophic in the OT if the surgeon comes across it on opening the patient. So excellent exercise.
Thank you.
So I go on with the next speaker, and for this we have Dr. Bijoy Balakrishnan. He is the head of the department CMAR Fetal Medicine Unit and the first fetal medicine unit of Kerala. He is the past president of the Kerala chapter of SFM, and he is a teaching faculty for Gynae Academy, scholar MD, and FNB in perinatology. He has got a FNB course going on in his center. And Dr. Bijoy is the best person to give us new insights on late onset anomalies, and maybe his way of taking this lecture, I will be very well interested to listen to. All yours, Dr. Bijoy, for an interesting lecture. From the beginning, I'm saying.
Thank you, ma'am, for those kind words. Let me just share my screen. I hope my screen is visible.
Yes, Dr. Vijay.
Yes. Good evening, everyone, and let me start by thanking Bhaskar Pal sir and the entire team of Feature Vision for giving me this opportunity to be here. I must say that giving webinars is always very dicey. It all depends on two things. One is the network and the capacity of the people to stay awake so late in the evening. So I hope both of those things hold together for me. And when I talk about late onset anomalies, there is always this confusion. What is the difference between late onset anomalies and missed anomalies? Are they both the same things? So, if you have done a good anomaly scan at your 20 weeks and then an anomaly comes up later on, is that actually a missed anomaly or a late onset anomaly? Or do you use the term missed anomaly only for those patients who have not had a good anomaly scan? And most of the times, obstetricians and even imaging people have this wrong concept that if you pick up an anomaly, in the late third trimester, it's almost always going to be a rare anomaly if a good second trimester scan has been done. It cannot be an anomaly as simple as a diaphragmatic hernia or a hypoplastic right heart. It has to be something exotic, something that happens towards the later part of the pregnancy, and it cannot be a simple anomaly that can be picked up in the second trimester. And over the course of the next 15 to 20 minutes, I'm going to show you that that is not true. Lot of these anomalies that you think can be picked up in the second trimester have a method of escaping our detection and making itself visible in the third trimester. And when we look at anomalies that are being seen in the third trimester, you would find that picking up these anomalies is not just to make the diagnosis, but also to allow proper perinatal transition. If you make a diagnosis of diaphragmatic hernia, directly you're saving the life of that fetus. And that's why it's important to make this diagnosis and not understand, and also understand that it's not because you have missed it. And in this paper, where they've looked at all the anomalies that have been acquired or seen in the third trimester, they were not rare or exotic anomalies, and most of them involved each and every system that you can think of. So let's go across these systems one by one. Let's look at this paper by Millinger, which looked at third trimester anomalies that were picked up after a normal second trimester scan. Around 17% of CNS anomalies were picked up in the third trimester. Now, if I ask any fetal medicine specialist about what these anomalies could be, almost all of them would say that it could be a migration abnormality. It could be a migration disorder, which would have been definitely picked up in the could be picked up only in the third trimester. It can't be anything else because we have done a very good second trimester scan. But if you look at their list of anomalies, you will be surprised that the most common anomaly that was picked up in the third trimester and was missed in the second trimester was the corpus callosal anomaly. An anomaly that we take a lot of pride in picking up in the second trimester, thinking that we have a foolproof method of making the diagnosis in the second trimester. And if you look at the second most common anomaly, it's going to be a ventriculomegaly. And migration disorders are very, very uncommon, and they are not the most common anomaly that you would pick up in the third trimester. And our diagnosis of agenesis of corpus callosum completely revolves around this fluid filled box, the CSP. We do not look at the corpus callosum in its entire length in all our anomaly scans. We just look at this box and make the assumption that the corpus callosum is normal. Now, we should understand that this box can be present both in complete and partial agenesis. Maybe the shape of the box may be different, and that's why, because we don't pay a lot of attention to the shape at times, because of a number of factors, could be the position or the habitus of the mother, there is a chance that you could miss on agenesis of corpus callosum. And in those cases, at 36 weeks or later, you may land up with colpocephaly and an absent corpus callosum. And in this patient, there was a completely normal anomaly scan. And if you look at these images, you can see that you'll be probably wondering, how can this be missed? But when we went back and looked at these images at the anomaly scan, we did find that there was a small collection of fluid in the center, but at the 20-week scan, but that did not confirm to the proper size and shape of a CSP. But sometimes you may find a normal size and shape of the CSP, as you can see in this case. The CSP does look normal in the sagittal and the coronal sections, but on closer interrogation, what do you find? You find that the anterior portion of the corpus callosum is completely absent. Again, a condition that probably can go undetected in the second trimester, and we picked it up only by chance in this particular case. Now, it's not just the presence or absence of a portion, it could be the thickness of the corpus callosum also that could be abnormal. And when it is very thick, there is a strong possibility of migration disorders. And as you can see here, the box that we are so fond of looking would be normal in your axial section, but you can see obviously that this corpus callosum is pretty thick, thicker than normal, and these conditions could later on develop to have migration disorders as well. Now, apart from corpus callosum, there are other things that we're worried about in the brain, like clefts, cysts, and of course, migration disorders. Now, here is an example of a woman who had a completely normal anomaly scan, and towards the early part of the third trimester, this is what we found. We found a connection between the arachnoid space and the lateral ventricles, which was confirmed in our sagittal sections as well. And on reviewing her anomaly scan images, we found that the axial sections were completely normal. There was the CSP, there were the lateral ventricles, and your transcerebellar plane telling us that all these sections were completely normal. So why did this cleft suddenly appear in the third trimester? And this is what we call as a schizencephaly. And this could be an acquired anomaly because it is happening. It can become visible later on, but this is an anomaly that can be missed because the space in this connection might not be visible in your second trimester. But sometimes when you do your third trimester scan, you can get bizarre cysts like this in the brain, and the sagittal section of the brain is clearly normal. And this patient also had a completely normal 20-week scan, but this happily is an arachnoid cyst, which would not cause any serious implications to the child, and this child had a good perinatal outcome. And then, of course, there is the common culprit where you have migration disorders. Now, in this axial section, this brain does look okay, except for the fact that it is pretty smooth on the outer edges here. And on a sagittal section, you can see that there is a large amount of subarachnoid space, and you can see that there is an absence of gyrations here in this surface of the brain, and you know you're dealing with a lissencephaly. So brain anomalies are easy to miss, especially because majority of them can occur or may be acquired in the third trimester, and also because we limit our evaluation to just 3 planes of the brain. But what about the face? When we come down to the face, I'm not worried about cleft lips and palates, especially the hard palate clefts, because they should be picked up. Soft palate cleft is something that we will most likely miss even in the third trimester. But sometimes you can get innocuous findings like this, where you have a cyst sitting in between the orbits, which can cause a little bit of alarm to the patients as well. But it's just nothing but a collection of fluid because of obstruction of the lacrimal ducts, and it's nothing but a dacrocystocele, which will resolve on its own completely. Coming to the thorax, if I asked you which is the most common anomaly that you can miss in the thorax, I don't know how many of you would agree, but most of you would say that it can't be anything as simple as the diaphragmatic hernia. But if you look at the detection rate of diaphragmatic hernia, you would find that it's only around 60%, and the mean gestational age at which you would make the diagnosis of a diaphragmatic hernia is around 24 weeks, much beyond our routine window of looking for anomalies in the second trimester. Now, this happens because the hernia happens late, but the defect is always present. And the hernia happens due to number of factors like the size of the defect and also the increasing pressure within the abdominal cavity. And despite of the fact that we have good ultrasound, every 4 hours a new case of diaphragmatic hernia is going to be born. And that's because this defect can become obvious very late in pregnancy, or sometimes the defect may be so small that it can escape detection completely. And here is an example where you have the heart being pushed to the right side, and I can see that there is something here near the chest wall, and it could probably be bowel, but I'm definitely not seeing any cystic structure like the stomach in the thorax. And going sagittal, I can see the diaphragm very clearly. I can see the abnormal position and shape of the stomach, and this small collection of abnormality that I can see underneath the chest wall is showing visible peristalsis and is probably the bowel. And my confirmatory diagnosis would be when I switch on color Doppler and I can see the course of the superior mesenteric artery as it goes across the diaphragm and feeds the the small bowel, telling us that we're looking at small bowel herniation, something which can be completely missed if you do not pay close attention to the axis of the heart. The same thing happened here as well. These are 20-week scan images of the thorax, and the heart does look normal, but if you pay close attention, you would find that the heart has been pushed to the left. And I don't see any space occupying lesion here on the right side. And in the third trimester, we were able to see that same shift across the midline. And on switching on color, we could see obviously that the portal and the hepatic vessels, which should be below the diaphragm, is sitting behind the heart, and therefore we are looking at a right-sided CDH. So CDH is something that can be missed in the thorax, but what about the fetal heart? The heart is completely formed by 8 weeks. So if there is an anomaly, shouldn't we be able to pick it up by 12 weeks and 20 weeks? And I see a lot of amazing pictures of anomalies that are being picked up at 12 weeks and 20 weeks. But we should always understand that we are never foolproof. There is always going to be an anomaly that is going to escape detection. If you look at these images on the right hand and the left hand side of your screen, this does look like a pretty okay and decent heart. Four-chamber view looks fine, the outflow tracts look fine, and probably on a fast cursory glance, you would pass this off as normal. But on closer evaluation, you can see that there is something jutting out from the walls of the ventricles. And when I go into the confirmatory view for cardiac tumors, which is basically your sagittal section of the both the ventricles, you will find that there is indeed a tumor mass sitting on the walls of the left ventricle, and this was the case of a rhabdomyoma. But it's not just tumors that we are worried about, because if you look at the heart, there could be things that develop in a completely normal heart, and the next one is something that is intrigued us completely. This was a 20 weeks completely normal scan, 27 weeks, and this is what we saw. A very small left ventricle, and you can see here that the apex of the heart is formed by the right ventricle. And we have always been taught that this can happen only in HLHs. But this was not HLHs. Both the outflow tracts were completely normal, but for some weird reason, the left ventricle was small and dysplastic, and the right ventricle was forming the apex of the heart. Unfortunately, this case was lost to follow up for us, but this was an important example as to why some of these babies, even after having a completely normal heart at 20 weeks, can land up with something as severe as this. When we come down into the abdomen, we are primarily dealing with cysts. Cysts in the abdomen could be in the ovary, it could be mesenteric cysts, but we're largely worried about basic bowel dilatation, which can happen only in the third trimester. But outcomes are extremely good if we pick this up and we ensure good and proper perinatal transition. When we come to the kidneys, the most common renal anomaly that we're going to see is hydronephrosis, and most of them resolve after birth unless the renal diameter is greater than 10 millimeters, when they would require surgical correction. And it's important to understand that not all of them are PUJ obstructions or lower urinary tract obstructions. If you look at this case on the left hand side, you can see that there is severe hydronephrosis on one side, the bladder appears distended, and the opposite kidney looks normal. Let me pause it for you and take you to these bookmarks. And you can see here that there is a completely normal kidney on one side, and on the other side, you have a kidney that is showing changes of hydronephrosis. Now, yes, it did look like a PUJ obstruction, but when we looked at the ureters very carefully, we did see that the ureters were opening and closing, as you can see here, beautifully closing and opening, telling us that we are looking at a vesico-ureteric reflux rather than a complete obstruction. When you look at the skeletal system, one of the most common things that we are afraid of is achondroplasia. And here is a case at 20 weeks, completely normal scan. And at 34 weeks, we find that the FL is less than the first centile, the foot length looks normal, and the FL by foot length ratio is 0.76, telling us we are looking at skeletal dysplasia, something which we cannot predict at 20 weeks. Although there are signs like metaphyseal flaring, which can be looked at, but it does not have a high positive predictive value to tell us that yes, this child is going to develop skeletal dysplasia later on. So these are surprises that we cannot circumvent. But the biggest surprise of them all is going to be this particular entity, an amniotic band sequence, where you will have a completely normal 20-week scan, and in your third trimester, you might find a baby that is completely abnormal with defects ranging from limb reduction defects to clefts to anything that can happen around which because of this particular amniotic band. And here is a case where we had a completely normal anomaly scan, but luckily at 24 weeks they came back for a scan, and this is what we saw. If you look at this lower limb, you can see that the lower limb is intact till the knee and up till a bit underneath that as well. You can see the the both bones of the leg, but they seem to be abruptly cut short. And on further evaluation, you can see that there is a nice thin band running through the amniotic membrane, and this is an amniotic band sequence. And because of all these problems, the recent ISWA guidelines that came out in 2024 stressed upon the fact that there needs to be a fetal anatomical evaluation between 32 and 36 weeks. They said that the best time to do that would be at 32 weeks, but we also understand that if you want to pick up cases of late onset FGR, you would have to do a scan closer to 36 weeks. So there is a lot of debate on whether this has to be done at 32 or 36. My opinion would be that you should do two, one at 32 and 36 in order to make best use of ultrasound so that you can pick up all your anomalies at 32 and all cases of growth restriction at around 36 weeks. And they said you have to pay particular emphasis to the brain, heart, abdomen, and the genitourinary system because these are the organs in which you're going to get late onset anomalies most of the times. But as you have seen through my slides, anomalies can happen anywhere at any time. And the biggest argument for doing a scan in the third trimester to pick up anomalies is to ensure that these children have good perinatal transitional care. Because when you have good perinatal transitional care, you're improving their chances for survival. And as the adage goes, it's better late than never. Thank you so much for listening.
Thank you, Dr. Bijoy, for such a nice lecture. Mostly 25% of anomalies, even in a place like King's, missed out on anomalies and were picked up in the late trimester. That's how we started looking at late anomalies, and this guideline has come up in the third trimester anomaly scan. And as you very correctly said, that even if it is diagnosed late, at least we give a good perinatal outcome by at least having them in utero transfer to areas where you have good pediatric surgery, pediatric medicine, and ICU and maternal care together. So I think late, even if it is late, it is very important to diagnose these disorders. And I think now we can give it over for the very interesting panel on fetal growth restrictions. And we are all set to listen to all the stalwarts. And Niharika, maybe you can take it up from here to introduce all of them.
Thank you so much, ma'am. Special thanks to both our chairpersons, Dr. Chanchal and Dr. Vandana, and also to all three speakers. We are right on time, which is very, very rare. So, thank you to all of you. Before we start our second session, I would request a small video by our academic partners. So, after that, we'll start our second session, and Dr. Shyama will take over from there.
From the sandy shores, where a couple stands hand in hand, witnessing the birth of a new day, to the boat sailing towards the horizon, seeking its abundant catch, the rising sun signifies a fresh start, a beacon of light guiding us towards a healthier future. A mesmerizing sunrise, symbolizing hope, transformation, and possibilities heralding a new beginning. Just as the sun's rays fill the sky, illuminating the world around us, we at M-Fine Diagnostics are here to illuminate the path to a healthier tomorrow with the promise of transformation. In this symbolic moment, we invite you as M-Fine Diagnostics, formerly known as LifeCell Diagnostics, embarking on a journey to revolutionize India's healthcare system. With the recent acquisition by LifeCell Diagnostics, M-Fine Diagnostics combines the strengths of two leaders, forging a path towards a healthier India. Our commitment to excellence, nurtured by years of experience, will redefine the way healthcare is delivered.
At NRL, we cater to a test menu of 3,000 plus tests. These are all specialized tests, and they cover various high-end specialized tests like genomics, karyotyping, FASH, newborn screening, prenatal screening, immunohistochemistry, allergy, and flow cytometry.
Come, let's explore a realm of innovation and compassion. Here, the convergence of science and care sets the stage for a new era in healthcare. Inside our state-of-the-art facilities, skilled medical professionals work tirelessly, employing the latest advancements and breakthroughs. We believe in leaving no stone unturned in our pursuit of accurate diagnostics and comprehensive care. With MFine Diagnostics, you can trust that your and your patient's well-being is in the hands of dedicated professionals, guided by a shared vision of transforming lives. At MFine Diagnostics Lab, we combine expertise, advanced techniques, and timely reporting to provide you with the most reliable histopathology services. Trust us for accurate diagnoses and comprehensive solutions. Our integrated departments and highly trained professionals equipped with advanced technology deliver high-tech tests with speed and accuracy. Automated sample management guarantees faster results, while our focus on quality is unwavering. At MFine Diagnostics, we prioritize seamless experiences for patients and doctors. Our dedicated customer care ensures hassle-free services, patient convenience is key, and we offer real-time logistic tracking, allowing patients to stay informed about their specimens. With strong logistics support and real-time sample tracking, we ensure smooth operations. Our mobile application provides a flawless user experience, enabling easy test searches, bookings, and result downloads. Our enhanced customer experience includes auto-routing bookings to the nearest available phlebotomist and a user-friendly portal/mobile app. Our skilled phlebotomists collect samples efficiently, maintaining specimen integrity during transport to the lab. Adhering to NABL and CAP guidelines, we uphold the highest quality standards in the industry.
Together, we can set new benchmarks of performance and excellence across the country. We are excited to collaborate with you in catalyzing game-changing diagnostic innovation for those who need it most. Thank you for your support.
Yes, I think very good evening to all. I'm taking over the second session. And as we all know, Bhaskar sir, definitely this slide has to go on to all the groups, all the talks that we give, because definitely he is a leader with a vision. So if we can now move on to the second of the session. Thank you to our academic partners. And now, fetal growth restriction. As we all know, as we all have seen, that this is one of the most important and even currently research topics, right? So that is because fetal growth restriction, definitely it is one of those important points that we have to keep in mind for any patient who comes to our OPD. Beyond the third trimester, when you see many a times scans, they come across telling that the fetus is small, it could be a growth restriction and SGA. So here is where it is very important that we have to focus on this topic, improve the perinatal care, reduce the risks of stillbirths, and thereby we enhance the health outcomes for these individuals. So now for that, we have a wonderful panel, a very wonderful panel with the panelists, the moderator being none other than our Devasmita madam. Professor, she's we all know her very well. I don't think I really need to introduce her, but officially, definitely, she's the unit in charge at Krishnaya Institute of Cardiac and Fetal Sciences, and we have seen her during our recent FetoVision conference. One of the coordinators. She is currently the secretary of Fetal Medicine Division in the Bengal Obstetrics and Gynae Society. And she has been a speaker and workshop coordinator in many of our national and international conferences, presented papers, won awards, and published more than 40 articles. So over to you, Devasmita madam, for the wonderful panel on FGR. I would ask you to introduce your panelists, esteemed panelists.
Yeah, thank you so much, Shama. My
Yes.
esteemed panelist is Dr. Rania Basu. She is MS DNB, MRCOG, and Fellowship in Fetal Medicine. We all know her. Consultant in Fetal Medicine, Fetomed Wellness, and Suraksha Diagnostic Private Limited, and Ankuran IVF as well. She is a really, really hard worker as well as a budding fetal medicine specialist, very young. Thank you. Next, my panelist is Dr. Joshna Rani Panirai, she is one of my respected senior. She was doing my fetal medicine. She was also my senior and also my fellow super guide and everything. Actually, you can tell. She is a consultant in fetal medicine and gynecologist, a past president of Society of Fetal Medicine from Odisha chapter. Dr. Malati Prasad, anybody knows her actually. She was the past president of Tamil Nadu state chapter of state chapter of Gynae Society, as well as she has won first prize in paper of fetoscopic skin, best paper prize in Yuva Fauji. There is many kinds of given to her, and she is the director of Chief Fetal Medicine Fertility Center, and she is a member of many kind of society. And I would like to introduce Dr. Megha Kamalapuram. She is a director of Devadatta Hospital in Gulbarga, Karnataka, and she is the chairman of Fetal Medicine and Genetics Committee of Gulbarga Society. That's really nice, and she has got a executive committee member of Society of Fetal Medicine in Karnataka chapter as well. Really nice to welcome you, Dr. Megha.
Thank you.
Dr. Vinita Singh, and she is the additional professor of Obstetrics Gynae Society names Raipur, and she is fellow and faculty of ICOG and secretary of ISCG, and area of interest is fetal medicine, infertility, endoscopy, and surgery, and she is the in charge of fetal medicine department at AIIMS Raipur. I would like to welcome Dr. Vinita Singh as well. Really, I'll be really happy to have some very good panelists around me. And Dr. Shankar De, he is one of my good friend, and he has done his MBBS from Arjikar from Kolkata and trained in advanced fetal imaging from Paras, Ahmedabad, and secretary of fetal medicine of fetal medicine Bengal chapter, as well as he is the secretary of Asansol of Obstetrics Gynae Society as well. My next panelist. I would like to introduce Dr. Sujit S. Dr. Sujit is from Aurangabad, and he has got basic ultrasound training from Bimal Sahni Sonoscan Center, Dr. Bimal Sahni Sonoscan Center, and he is the vice president of Society of Fetal Medicine from Marathwada chapter, and he is the chairperson of Fetal Medicine Committee of Aurangabad Obstetrics Gynae Society as well, and he is director of Sri Hospital, and he is one of my good friend as well. Nice to be in the podium with all of you. Should I share my screen right now?
Sure.
Yeah. First of all, I'm really glad to be the part of the Fetovision, that is the visionary part of the fetal medicine initiation by Dr. Bhaskar Pal, my respected seniors, and Dr. Sitaramamurthy Pal. I'm really thankful to you to invite me on this podium to share my knowledge with all my colleagues. Thank you so much. So we are going to discuss on fetal growth restrictions today, and why we are actually discussing about this thing. We all know about the Barker's hypothesis, that is the fetal origin of the adulthood disease. That is what happens here, that is inside the mother's wombs, that predicts our adulthood, and that is about the disease in the adulthood, as well as whatever we are thinking about the diabetes, cardiovascular diseases, hypertension, what the adulthood we are suffering, that is actually programmed inside the womb from the beginning. That's what we want to tell about, and that's why we are worried for, and that's why we are here. Not only it's about the neonatal complications, it's about the adulthood complications, longing for the thing. So complications related to fetal growth restrictions, it is almost 10% of the incidence, and stillbirth in less than 10 centile, it has been seen almost 1.5%, and stillbirth in less than 5% of the effective fetal weight, it increased up to 2.5%. So chromosomal aberrations in fetal growth restrictions with the structural anomalies, it's almost 20%. But when it is isolated fetal growth restrictions, it's almost 9%. So placental hyperperfusion in fetal growth restriction is usually associated with 25 to 30%. These are really, really important mnemonics or numericals we need to remember in the fetal growth restrictions. And effective fetal weight, when it is less than 10%, the baby can survive, may survive with severe acidosis. Apgar 5 minutes less than will be very less, and NICU admissions will be increased. Cardiac remodeling to the adulthood also increased. So I welcome all my discussants. I have already told. So my first questions to Dr. Ananya Basu. What will be your prevalence and causes of IUGR? Would you like to discuss on that way? Dr.
Yes, ma'am.
Ananya?
Yes, ma'am. Am I audible, ma'am?
Yeah, of course.
Okay, thank you, ma'am. So, the prevalence of FGR as cited in most of the literature varies between 5 to 10%. More precisely, by ISOC, it is 7.7%. And if we enumerate the causes, then the causes can be classified into three categories: the fetal causes, the maternal causes, and the placental causes. So, the fetal causes could be some kind of aneuploidies or chromosomal issues in the fetus, or it could be some kind of single gene mutations or some congenital abnormalities or non chromosomal syndromes also. Sometimes it could be torch infections or the infections like malaria or syphilis. Then we move on to the maternal infection, maternal causes where some maternal pre-existing conditions like pre-gestational diabetes, like chronic hypertension, connective tissue disorders in the mother, or multiple pregnancy, then IVF conception, extremes of maternal age, maternal cocaine abuse or nicotine abuse in the pregnancy, all this can also contribute to that. Then coming to the placental causes, which are of course very important, then placental infarcts, placental vasculopathy, and of course some abnormalities in the structure of the placenta like piloplacenta, and sometimes cord abnormalities like single umbilical artery, or it could be because of filamentous or marginal insertion of the cord. All these are the spectrum of causes contributing to fetal growth restriction.
That's wonderful. I want to just point out one thing, that chromosomal mosaicism confined to the placental tissue can be also one of the cause, very prominent cause rather. In cases of isolated FGR, it is almost 9 to 16% of the incidence. So wherever we are not finding any kind of cause, that is can be a CPM also, confined placental mosaicism also. So these are the causes you have already explained very well, actually. So I want to ask my respective senior Dr. Jyotsna Panigrahi, how to date the pregnancy correctly. Before jumping to the diagnosis of intrauterine growth restrictions or small for gestational age, it's very important to date the pregnancy properly. Then we should go ahead. Ma'am, please go ahead.
First of all, I am
Jyotsna
thankful
di?
to everyone. Yes, am I audible?
Yeah, yeah.
Am I audible? Yes.
Yeah, you
So,
are audible.
yes, yes. Thank you. Thank you everyone for giving me this opportunity. So the first and most important is taking a proper menstrual history. When you see the patient, first look to the all the documents here and what the menstrual history is and what is the type of conception. These three are important first step when the patient enters to you. The next, whether the patient came in the first trimester or in the second trimester or in the third trimester. If she is in very early pregnancy, when you see no fetal pole in the uterus, then the dating should be by the mean sac diameter. Mean sac diameter plus 30 is the gestational age. At 6 to 9 weeks, again the CRL, but don't give the EDD because at that time it is actually not the CRL, rather it is NRL or neck rump length. So the most important time to date a pregnancy is in our first trimester, sir, 11 to 13 plus 6 weeks. Here, the another important thing is that whether the patient had done the ultrasound earlier or not, that you have to look after. And proper CRL is the gold standard or mainstay of dating the pregnancy. The CRL, I am not going to detail of how to take. Only thing I want to say that the line of CRL measurement should be 90 degree to the ultrasound beam. That means the baby should be very, very horizontal. Take the 3 CRL and take the mean and take the largest. Take the mean of the all three properly, discretely taken CRL. And once the CRL is assigned and EDD is assigned, then don't never change the EDD because you have already assigned it. Remember it, this is the common mistake done by all the gynecologists or ultrasound, whatever it may be. So if the patient comes at second trimester, look to the 13 week scan, if already is already given, and look to the image by what they have given the EDD. That is most important. If you think that that image is not good, you measure the measurement and give the EDD by the biometry. Out of all the biometry, the most important is head circumference and femur length. These two are important. Once if you give the EDD, don't change it because after that there is the growth, not the gestational age. After 24 week, gestational age is usually not given. And while giving the biometry for the correct dating, be assured that FL and HC should agree to each other. If there is disparity in FL and SC, again revisit your caliper, measure it again. If again actually in true sense there is disparity, then there are so many differentials you can go through. And in twin pregnancy, take the CRL of the largest twin. Is it okay?
Thank you so much for such a wonderful answer. So, Dr. Malathi, yeah, request Malathi to diagnose. Yeah.
Yes. The person who was
Dr. Malathi, can you
advised
diagnose this case? Can you, ma'am, read out all these things? Should I read out for you?
Yeah. No. No getting just here. I'm not getting managers. No signals.
I think the Basmita madam,
Yeah, she's lost signal.
she's lost her
Signals.
signal. I'll just see. Ma'am, can you share once more you're on mute, madam. Demasmita madam, you're on mute.
You cannot see her also.
You can call her. You can call her and say she's in mute. She doesn't know, I think.
Yeah.
Yes, trying, ma'am, trying.
You can. And the other one thing I missed, if the CRL is difference is 2 weeks or more, you can change the 1 week or more, you can change the EDD at the first trimester.
Yes, ma'am. As madam already said, we should not change the EDD once it is fixed in the first trimester, because once you do it in the third trimester, we are actually missing out
Can you
the
see
data
the
rate
slide?
here.
Can you see the slide?
No.
Can you
No,
see the
ma'am, we
slide?
are not able to see.
No?
Yeah.
Devasmita, you are muted.
Why?
Yes, I can see this. I can see the screen now. I can see the
I'm unmuted only.
abdominal circumference. Yes, there is I can see the abdominal circumference do less than the percentile.
I'm unmuted.
Estimated fetal weight, which is less than the percentile. And elevated, I think, pulse factor index of the uterine artery with the reduced diastatic low. So the nomenclature here is maybe more than the 9th percentile.
I'm not able to share my slides only.
Yeah, no, I can see your slide.
I'm not muted in my screen actually.
Himanshu?
Yeah.
I'm unmuted only. Hello?
You just log out
You can
and
see my
again
slide?
log in.
Can you see my slide?
No,
Now
ma'am.
it is there.
My slide?
Your screen is seen, madam.
Slides are seen?
Slides are not
No.
seen. The screen is seen, madam.
Now you have to start again.
Just start it again.
Start the PPT. Start the PPT.
Start the
Yes.
PPT. Yes.
Yes.
Fine.
Yes.
Yes, ma'am. We are able to see it now. This is the first slide, no?
The first slide. You can see the first slide.
Business organizations.
That's going to be a difficult one.
I think madam has got a poor connection. The call is also not going through.
I think the reverse flow with Dr. Vinod is the picture that you saw. I think W-Clattery PI was maybe more than 9th percentile. So it's included the case of stage 1 LCR. No? So how getting the forms?
Is everything okay?
Yes, now it's okay. Start again.
Yeah. Yeah. Yeah, ma'am. Can you please diagnose this?
We are not.
I cannot see the
Hello?
images, but I already see
Hello,
the
ma'am?
images, so it's okay. Yeah.
Yeah, it is okay?
No,
Yeah?
I'm not able to
Can you see
the
this?
image.
Yes,
Yes,
just
I noticed the one with the AC, yeah. So as you can see, the circumference less than the percentile, yes, it's huge, this is second percentile. And you can see the elevated CI, the diastole is not related now
Go
to
to
the.
slideshow mode.
Hello?
Go to the
Yeah.
slideshow mode.
Hello? Can you see my screen?
yes,
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 yes, I can, I
Your
can, I
yes.
can.
screen.
Ma'am, please tell the
And
diagnosis.
this is DD is showing a reversal. So already gone in for stage 4 FGR.
Yeah, it is a stage 4 FGR actually.
FGR.
We will go to further the things. This is another case, ma'am. Can you please diagnose?
This is it looks like a placental hyperinflation syndrome.
Yeah,
The
ma'am.
placenta is huge, thickened,
Yeah.
absent diastolic flow, TB reversal, urinary pulsatile index is high. Again, stage 2 tissue growth rate. No, stage 2. Stage 2.
Yeah,
Can I
ma'am.
know the pulsatile index of renal?
Yeah, pulsatility index of the DB was high basically, rather. It was not
If it is more
reversal,
than 9
but umbilical
percentile, you have to go to
was.
the stage 3.
We will come to the staging later basically. I'm just
Yeah,
putting the
yeah.
diagnosis of different kind of causes of IUGR basically here. So how they actually look about the thing. Yeah,
This is
ma'am.
typical case of placental hyperinflation syndrome.
Yeah,
What we
ma'am.
saw.
That's very true. That's very true.
Yeah.
So I would like to go to Dr. Megha Kamalapuram regarding the enumerate the pathophysiology of IUGR.
Yeah, at the outset, I would like to thank the organizers and Bhaskar Pal sir for giving me an opportunity to be the part of this program. And when we consider the pathophysiology of IUGR, it is basically divided as three. That is maternal vascular malperfusion, fetal vascular malperfusion, and third is vasculitis of unknown etiology. Comprising together as a placental insufficiency syndrome. And if we rule out this with normal Dopplers, then we have to look into other causes as have been described by Dr. Ananya as fetal chromosomal abnormalities or congenital abnormalities, congenital defects or maternal diseases or maternal smoking or other placental pathologies. But the basic pathology lies in three. That is, I would reiterate, that is maternal vascular malperfusion, fetal vascular malperfusion, and vasculitis of unknown etiology.
Yeah, very nicely described, Dr. Megha. This is all about the early onset of preeclampsia, late onset of preeclampsia, early onset of IUGR, late onset of IUGR. These are all actually about the spiralatory remodeling on the inflow of the maternal blood flow into the placenta, how it is actually having the vasoconstriction pathology, what we have already read in our MBBS days actually. So early and late onset of FGR, I want to stress on, represent two distinct type of phenotypes of the same disease, the same placental vasculitis, same placental pathology. That's what we want to stress on actually. Only the timings are different. So while identifying the small fetus, we need to go for the different arenas of that small fetus. One is early IUGR, one is late IUGR, one is small for gestational age, one is IUGR versus small for gestational age. That's what we are thinking, and early versus late. So I would like to request to tell about what Dr. Vinita Singh, what are the implications of multivessel Doppler and which are the vessels we sample to diagnose IUGR?
Yeah, thank you, ma'am, for this wonderful panel. I'm obliged. Yeah, we always need to sample uterine artery at the very onset of when you're doing the combined screening. When we scan, we need to sample uterine artery and also ductus venosus. And also we need to sample if it is early onset FGR, we have to also see the umbilical artery and ductus venosus, and in the late FGR, we also see middle cerebral arteries to calculate the cerebroplacental ratio. And sometimes we do look on aortic isthmus, but not that frequently in our clinical practice. But these umbilical artery, middle cerebral artery, ductus venosus, uterine artery definitely play a role all through the pregnancy.
Yeah, very nicely told. One is fetal part, one is maternal part. So these kind of Dopplers, the vessels that throwing to the placenta, that is supplying to the maternal, we need to go for all the sampling actually. So if we are going for the maternal compartment at the fetal compartment, we can see the uterine artery notching, the pulsatility index increase, that decreases the intervillous perfusion, and umbilical artery we can see that is when shown. If it is increased pulsatility index, the 30% of the placental damage is there. If it is absent end-diastolic flow, the 50% of the placental damage is there. It's almost reversal, then it is 70% of the placental damage is there. So we need to think about all these things. So I would like to request Dr. Shankar De to explain the cascade phenomena of early IUGR pathology with Dopplers.
Thank you, Dr. Devasmita. And at the outset, I want to express my sincere regards to Federation Scientific Committee to give me this kind of a opportunity today. Actually, what happens if we think for the pathophysiological aspect, then we can understand that how to explain it in the Doppler phenomena in this early onset FGRs. Early onset FGRs has a typical cascade of phenomena in the Doppler changes of a if you do ultrasound from the beginning. So what happens in initial phases because of the abnormal uterine artery, spiral artery abnormalities in the placentation. During the abnormal placentation, what happens? The maternal portion of the villi are smaller, so there is increased resistance to blood flow. That indicates in the uterine artery PI. The uterine artery PI gets more than 96% initially. Then when the disease gets progressed, then the middle cerebral artery also there is a phenomenon known as the brain sparing. That means the brain is spared, means the middle cerebral artery get dilated and some diastolic flow is increased. So the CPR gets changed. That means the cerebral placental ratio, and then we start the umbilical artery also is increased more than 95th percentile. So after the umbilical artery gets more than 96th percentile, then we can have some phenomena like absent end diastolic flow or reversed end diastolic flow. In between, then absent and reverse flow in umbilical artery because of increased resistance in the placental bed. We can have aortic isthmus abnormality. The vessel here comes into play is the aortic isthmus, where we can see a shift from a normal forward flow to a pulsatile flow more than 96th percentile or even in reversal. Then it's a velar section that gets affected. The precordial, the ductus venosus, when it gets more than 96th percentile and pulsatility increased, and if there is a disease progression to a very severe end, then we can have the reversal of the ductus venosus AOF. That reversal of the ductus venosus AOF is the clinching point where there is no actually no reversal of the disease process. So that is the point when we need to consider the delivery, the stage 4-1. And then if we do CCTG, then we can see the reduced short-term variabilities. And finally, it's not Doppler, but the CTG that will be abnormal just before the serious injury or the before the death. In such cases, to prevent those things, this cascade of phenomena we have to understand in a very good way and implement our ultrasonography parameters to save the lives of FGR babies, especially the early onset FGR ones.
Yeah, wonderfully told, actually. That's really nicely told.
Thank you.
So, we have got tools to detect FGR. That is basic ultrasound biometry, growth velocity by growth charts, multivessel Doppler that we already discussed, Doppler for uteroplacental insufficiency, Doppler for fetal adaptations. So that's what we have described in a nice way. So I would like to ask Dr. Shujit, which is better actually to express centile or growth velocity, or both are different? Which growth chart is ideal?
Yeah, thank you for including me in this panel. There are two parts of your question. First is velocity and centile.
Yeah.
So, regarding centile, it can be put on when you see on one occasion, the last study shown that the perinatal mortality and morbidity is more or worse when the estimated fetal weight is less than 10 centile and more than 90th centile. We are in a very good position when the estimated fetal weight is between 50th to 90th centile, and the chunk of the patients when the estimated fetal weight is between 10th and 50th centile, it is not immune. The parental morbidity and mortality is also not very low here. So this group is put under the late FGR group. Second is which chart to use. Actually, basically there are two types of growth charts. One is reference chart and other is standard chart. Reference charts, these are of two types. One is you call it as live birth chart, and another is estimated fetal weight chart. But the problem with this reference chart is that there are some babies which are included in this charts. These are preterm babies. Their babies are born with preeclampsia, PROM. Some babies are congenital malform. So there is a mixture of babies feti in this way. So the 10th centile comes lower in these patients. So we are going to miss out many SGA babies. In standard charts, we are using the fetus or babies which are grown under normal conditions. They are low risk, no complications. So it is always better to go for standard charts, the Hadlock chart, intergrowth chart, or you say WHO chart. These are the charts which are standard charts, and always go for these charts because 10 centile is near or same charts.
Yeah. Thank you so much. Would you like to stress on fetal growth velocity? Because when we are talking about intrauterine growth restrictions, fetal growth velocity matters a lot. How to
Yeah,
calculate
because
it? Yeah. Would you like to stress on that?
yeah, because we are happy to see the increasing trend. We are not happy to see the decreasing trend because if it is passing or passing more than two quartiles, it is one of the marker or element of definition of the late FGR, late onset FGR.
Yeah, that's very good. So how to calculate the fetal growth velocity? It is really simple. So we are taking the 2 gestational age with the 2 effective fetal weight. That is the 2 points we have to divide the gestational age by the effective fetal weight. The ratio of the 2 fetal effective weight and subtraction by the 2 gestational age, we have to calculate in that way actually. So that is very simple. We can calculate the fetal growth velocity in ourselves by this calculation, simple calculation also. Because fetal growth velocity is hampered in the intrauterine growth restriction inside the womb only, and that differentiate between the small for gestational age as well as intrauterine growth restrictions. So I would like to go to our next question. Is it necessary to have separate charts for twins? Why it is so, Dr. Ananya?
So this is of late a very burden the coming up of this. So it has been seen that the growth trajectory of the singleton gestations and the twin gestations is very different in the third trimester of pregnancy. So yes, the recent evidence suggests that if we are using the singleton based charts for the twin growth surveillance, in that case we may overdiagnose the cases as FGR, and in that case that would lead to many unnecessary interventions, sometimes iatrogenic prematurity and unnecessary prenatal anxiety. So at present, both ISWOG and FIGO are of the opinion that twin-specific growth charts should be used for growth surveillance in case of twin pregnancies rather than using the singleton charts.
Yeah, thank you so much. The twin pregnancies are characterized by slower growth velocity in compared to the singleton. That's why that's a nice point you told actually. We may overdiagnose also for the thing. So the twin chart should be standardized reference to the axis growth in the twin pregnancy. That's what. So we can see this green line, whatever it is normal about the normal pregnancy, the singleton, but that will be the slower growth velocity for the twins. This dotted line is about the twins and the solid line is about the singleton pregnancy. So I would like to request to Josna ma'am how to define IUGR. Though it is very simple, but various podiums is described in a different way. Josna ma'am, how to define IUGR?
So there are so many definitions for FGR or IUGR, but the definition for early and late onset FGR in absence of congenital anomalies is based on International Delphi Consensus. As per the ISWOG or Delphi Consensus, the early FGR is when it is less than 32 weeks and in the absence of congenital anomalies, and late onset FGR is when the gestational age is more than or equal to 32 weeks, again in the absence of congenital anomalies. This is important. So early FGR is defined as when the AC or effective fetal weight is less than third centile, or there is umbilical artery absence and diastolic blood flow, or AC and effective weight is less than 10 centile when combined with uterine artery PI more than 95th centile and or umbilical artery more than 95th centile. Here the common difference is one, there is less than third centile weight and the other is the less than 10 centile, and then you have to add the other two Doppler findings. This is about the early onset FGR. Regarding the late onset FGR, the same thing, AC or EFW less than third centile, or at least 2 out of the 3 following. What are the 3? AC or EFW less than 10 centile, SC or EFW crossing centile more than 2 quartile. This is very important on the growth centile. That means if the baby is, even if more than the 10 centile, this baby can be stamped as FGR if it crosses the more than 2 quartile of the growth chart. So, or CPR is less than 5th centile and umbilical artery blood flow is PI is more than 95th centile. So again, either the first one or any two out of the three. Then we can stamp it as the late onset FGR. This is the only definition, and I think we should follow and say the same language to everyone.
Yeah. So it is only for the diagnosis, but not for the strategic management actually. We can only diagnose it by. That is the only thing.
Yes.
So we can differentiate out early onset of the FGR. It is actually is a cardiac adaptation, but late onset IUGR is about the brain adaptation that we had seen through the Dopplers and many things actually. So this is all about the difference basically. So how to stage intrauterine growth restrictions, Malati ma'am?
Yeah. So once you have diagnosed the FDR and already said AC less than age of the percentile, it's important to state. Why is it important to state? Because it's important to monitor and have proper surveillance. Because early onset FDR are the one that require very close monitoring and surveillance, so that we have a normal life child rendered. The late onset is the one which is after 30 years, so easy to monitor. So stage one is where you have AC less than the percentile or 10 centiles with positive, umbilical showing a positive and diastolic flow. For example, that's stage one. In stage two, you have an absent diastolic flow and IOT is not more than 90%. In the stage which is suggestive of a severe planetary resistance. Stage three is the one where you have a reverse in diastolic flow of the DDCI more than 90%. So automatically, you don't have to wait for the reversal of CV. When you find the DDCI more than 90%, it is stage 3 FCR, but with a low suspicion of explosives. And when you find the reversal flow in the ductal neuron, you automatically recover stage 4 and with a high suspicion of situation. But the staging is important because it's easy. Based on this, you can just get the patient to come back for your monitoring and surveillance.
Can you diagnose the staging of this IUGR, this patient?
This is AC, which is
24 weeks. These are the thing. These are from the medical college specimen actually.
I think MC is high brain swelling.
Yeah, it is only the brain swelling.
Is
reversal. Yeah. Even the umbilical is reversal, and we can see the cardiomegaly is there also, and the almost the shrunken kidneys are there. Oligohydramnios is also there. So can you stage this FGR?
Stage 3.
It is stage 3. Ductus venosus is also reversal.
Reversal is stage 4.
Yeah, stage 4. So naturally, so the staging is so important because it also doesn't detect only for the diagnosis, it also detects the prognosis. So that's why we can counsel our patients in a very good way, as well as in the perinatal outcome, as well as in the intrauterine also. We can counsel the patient in a much better way when we stratify the staging more better way. So I would like to ask Dr. Megha, when to deliver an early IUGR? What is your opinion about that?
Yeah, as already you told, that the delivery depends upon the stage of the disease. It also depends. Our main concern for delivery of this baby is iatrogenic prematurity. So we need to consider the patient's consent, then local availability of invasive setups, and it is always the stage-based classification and management of FGR. So it is, if it is stage 4, as you have shown in previous case, with reversal of ductus venosus, and if the pregnancy is more than 26 weeks, we have to deliver this baby by cesarean section.
Yeah, stage 4 we have to do. And how you would like to follow up? Like somebody is with the stage 2, with the severe placental insufficiency, with the umbilical.
So these patients follow up. Every 4 days we can just call her up and follow up. And once baby reaches 34 weeks, we can take out the baby by cesarean section. And same, if it is grade 1 SGR or stage 1, then we can have a weekly follow-up, wait till 37 weeks where we have an option of labor reduction and deliver the baby.
Yeah. and it is severe, then bi-weekly, and according to the patient also, we have to like 1 to 2 days, 12 hours, we can do the follow-up like this actually. So this is the outcome of this truffle study. Would you like to describe about the truffle study? What is safety net? How you are going to go for the safety net? If you are going to deliver before 32 weeks, naturally the babies are really, really small. So one day inside the womb that can come into a 2% of the neonatal survival. So how you are going to go for the safety net? Dr. Megha? Dr. Megha? The safety net is by the computerized CTG. Can you listen, Dr. Megha, to me? Hello? It is by the computerized CTG. Yeah. Anybody can tell about safety net? It is by the computerized CTG basically. We have to go for the CTG and we have to see everything. So it is all about the thing that where we have to prolong
I think
the.
Dr. Megha is speaking, but we can't hear her.
Okay. Dr. Megha, please can you unmute? Yeah.
Megha, you are not
That's very
audible.
good.
Many other problems also. So it can mimic ovarian and endometrial carcinoma. It can mimic most of the time when there is
The mother voice is coming.
the women of reproductive age group. If patient comes with these symptoms, there can be genital tuberculosis. But if patient of the postmenopausal age comes to us with these symptoms,
Dr. Megha.
I think
you can.
I can continue the thing. So the safetiness is about the prolonging the pregnancy. We are stressing on the more and more factor about the prolonging pregnancy. That is most important, and that is being held by the computerized CTG. Right now it is available in India as well. So we can go for this kind of things. So Dr. Megha, there was another question also. Can I ask to Dr. Binita? Can you tell us about the protocols of the steroid and Maxolf? This
Yeah.
yeah, please
Yes. Whenever a patient comes before 32 weeks, we can consider for Maxolf as a neuroprotection, but it has not much benefit if we do it after 32 weeks. And for DEXA, we can always give DEXA till 34 weeks of pregnancy. And after that, like in our institute and our others say that after 34 weeks, does not have much role. But before till 32 weeks Maxolf and till 34 weeks DEXA, 2 doses of dexamethasone is advisable.
Yeah, for neuroprotection.
According to
Yeah, Dr.
RCOG,
Uh-huh.
according to RCOG protocol, you can give it the steroid one up to 36 weeks, 35 weeks plus 6 days.
Yes.
The current recommendation.
Actually, no. There are different societies with different viewpoints. Like somebody says that after 34 weeks, and definitely there is no role of repeated dexamethasone coverage because it causes leukomalacia and internal hemorrhage chance is increased. But there are different societies with different protocols. But pediatricians in our institute, they insist, please don't give steroids after 34 weeks. Definitely, ICOG has its own guideline. But pediatrician in our institute, and we have saved baby of 26 weeks also because of very good quality setup of NICU. So definitely, different institute have their own protocols. But in here, we don't give it after 34 weeks at all.
Okay. So many institutional protocols are there according to their observations in the neonatal outcome, and that is the thing. So neonatal survival rate that I was speaking about, 20 to 23 weeks, that can increase up to 13% of the neonatal survival. If that delivered is 28 to 29 weeks, it's almost 84%. So we can see if you can prolong the pregnancy by the truffle study that has been shown, we can actually win about the perinatal outcome. So another thing we want to stress upon the impact of the mild late IUGR and the small for gestational age, because even the small for gestational age can have the perinatal outcome with many kind of neurocognitive disorders and learning disabilities. So naturally, we need to know about all these things. Dr. Vinita, can I repeat a question about can you diagnose this case?
Ma'am, I cannot see this case on the screen. Yeah. Okay.
Yeah, can you see right now?
Yeah, I can see. Ma'am, can you just highlight the points because it's not
the abdominal circumference is less than 1 centile. Even
that is
the
FGR. Yeah, how much gestation age, madam? This is what is the gestation age? 37 weeks.
Yeah, it is a 37 weeks, but we are
And
getting
less than 1 centile is definitely it's a FGR.
Yeah.
And what about Dopplers?
Doppler's umbilical pulsatility index is 1.46.
What is PI?
PI is 1.46.
Okay, percentile. We need to know the percentile of this
It was
umbilical
98
artery.
percentile, 95th
90.
percentile.
So definitely it is still now it is stage 1. Then what
Yeah.
about this?
It is actually 1.46 is about 37 weeks. It is very high percentile, and it is
Yes.
37 weeks. The right uterine PI is 1.39.
Yeah, ma'am, we should always consider it by PI.
Yeah.
What is the percentile of the PI? That
It
is
is
how.
99th percentile. It is
Nice.
99th
So
percentile.
still, since it's 95, 99, then still it is stage 1 only.
Actually, then it is about the abdominal circumference. 33 weeks is less than 1 centile actually.
Yeah.
So should
Yeah,
I
but
go
still,
for yeah,
we
tell
have to go for middle cerebral artery. So look for CPR. And if CPR is less than 5 centile and 37 weeks is pretty good time for baby to deliver. So if every percentile is the patient is already 37 weeks and if we can see that percentiles are in the higher range, we can consider for delivery induction of labor.
Yeah,
If there is
my
no
stress
other
was
option,
on the what is
indication.
the diagnosis basically. Can we give it this diagnosis, this case to the late IUGR? Because we are
Yes,
getting
of course.
Doppler abnormalities and the ACC
Yes,
tells
yes, of course,
us
of course. Yeah,
that
yeah.
is the late IUGR
Yes,
case basically.
later,
So this is
yes.
another case for you. Can you diagnose this?
This is what 37 weeks and what is the
35
circumference?
weeks. This is at 35 weeks. MCPI was 1.64. It is in a normal centile. Umbilical PI was 1.01. It is almost 80th centile. And it is right
Okay.
uterine PI is 1.1 with the diastolic notch. It was in a higher centile, 95th centile. And the AC was almost 1.8 centile basically, 32 weeks, 3 days. That was really less. And the biparatal diameter, you can see the centile. Okay. So what will be your diagnosis about this case?
So this is also a case of FGR.
Yeah. So this is the case of
Yeah, stage 1 FGR. This is also stage 1 late because 32 weeks has been crossed. So it is also a case of a late FGR.
Late FGR. Okay. Thank you so much. So we are going to go for the differentiate between the small for gestational age with the IUGR before predicting about the late FGR, because this is almost a synonym kind of things entity that is called small for gestational age. They are with the same pathology also. Previously, it was thought that that was not with the same pathology. Placental pathology is not associated with SGA, but right now the theory has been changed. After 2018 onwards, it is SGA is also told as this placental pathology. Dr. Josna ma'am, can you differentiate the SGA and with the IUGR? Josna ma'am?
Yes, actually, yes. Am I audible?
Yeah.
So actually, this is a very, very difficult situation to differentiate these two. So many theories, so many confusions. The only I am telling the basic things. SGA is a reflection of constitutional factors such as gender, parental height, ethnicity, and they usually grow linearly and do not exhibit other parameters of fetal distress like oligoamnios or Doppler abnormalities. SGA fetuses may be small, but not at increased risk of adverse perinatal outcome. Usually, I say this word. But whereas FGR is the final manifestation of a variety of maternal, fetal, and placental condition, and 5 to 10% pregnancy it counts, and it is not only a major cause of perinatal morbidity, but it predisposes to the development of chronic disorders in later life. And placental insufficiency is the most common cause of FGR, while chromosomal abnormalities and congenital malformation are responsible for approximately 20% of FGR. Another important thing in SGA, it says the size of the baby. It doesn't have any growth velocity disorders, whereas FGR is a very low growth velocity potential. So to differentiate is mainly is the placental factors and the Doppler abnormalities, which is usually not associated with SGA.
Yeah. Thank you so much. So that is really nicely told by you basically. Small for gestational age can be divided into three kinds like less than 1 centile, less than third centile, less than fifth centile. So that's why this division is there, because we can despair about the perinatal outcome and we can make the disparity of their things and we can manage accordingly. Because HGA less than 1 centile is almost looking to the gamut of the IUGR. So they can have like this cardiac remodeling in the later on in the adulthood as well. So we need to be very careful about this. So Dr. Sujit, can you explain about how to screen late FGR? How you are going to screen about that? Is it possible to screen?
It is possible to screen, though late FGR is a late phenomena. The screening starts from first trimester only with you consider the maternal characteristics, biophysical parameters like uterine artery PI and blood pressure monitoring, then biochemical parameters PAPA and PLGF. Then in second trimester we add biometry and estimated fetal weight. And if the Doppler is abnormal, then detection rate again becomes high. And if we add again in last trimester, third trimester, sympathy fundal height in or a clinical acumen, then the detection rate again goes more than 50-60%. So this is the way we should screen the late FGR. But the most important basic thing is every growth scan should be done along with Dopplers. And in late trimester, especially in late FGR, you have to look for CP ratios, seroplacental ratio instead of the ductus venosus, all those things. Because the basic difference between early and late FGR is the amount of placental damage. The amount of placental damage in late FGR is less than 30%. So heart is very happy with that, and all the burden comes in the latter part on the brainstem. So the most important parameter to know the abnormalities or affecting the brainstem is the seroplacental ratio. And again, that is CTG, that is fetal heart rate abnormalities.
Can I just say one word?
Yeah, please.
So the early onset FGR, as you have told, it is a perfusion defect, whereas the late onset FGR is a diffusion defect. So already the placenta is good, and there is a diffusion problem between the placenta and the membrane of the fetus. Whereas in early onset, it is the placental perfusion defect, so it could be screened better than the late onset FGR.
The basic theory is in early onset FGR, the amount of damage is more than 30%. So from the start, the baby starts growing not growing well. Here, umbilical artery is always abnormal. But in late FGR cases, the amount of placenta damage is less than 30%. So till 28 weeks, 30 weeks, 32 weeks, the baby is growing normally. But after that, the remaining placenta is not sufficient for growth. Again, that the baby starts growing less, and then it lands in late FGR. This is the basic thing between, this is called a 30-70 concept. Basically, this is a 30-70 concept.
Screening is rather difficult in late onset FGR. Screening, I think, what you tell Devasmita, I don't know.
Yeah, that screening is difficult, but
difficult.
Yeah.
Management is easy. Here, the screening is easy, but the management is difficult.
Yeah, that's very.
Late FGR screening is really difficult because one thing, you don't miss the 35-30 week scan with Doppler. If you should not never miss that scan, you will pick up those cases of late
That's why,
FGR.
doctor, there should be a one screening ultrasound at 34 weeks. So many hypotheses.
That's what I want to stress on basically. If the pair thinking, tell me.
The baby may be normally on AGA at 32 weeks, but it can end up in late FGR at 36 weeks.
Yeah. So that is why they are stressing.
That carried the importance of 35-30 week scan.
Yeah. So ultrasound
Actually, I will call it not screening. Basically, we need to diagnose the cases at 30 to onwards just by using ultrasound and a Doppler. You cannot screen it fully. It's not foolproof. Any method is not foolproof.
Absolutely.
That's why you will end up in diagnosing a case. We cannot screen for them that this case is going to be a late FGR. Only you can actually if it is more than 90% from the beginning, then you can suspect that that will end up in that way. Otherwise, the Doppler abnormalities in late FGR is only 10 to 20%. So other 80% there will no Doppler abnormalities. Still, it may be a late onset FGR.
Yeah, very good told. That's why this paper is really a landmark that has been published in 2018. I have shown in the previous slide. They are stressing on that uterine artery PI, what we are calculating in the first trimester, we can again repeat in the second trimester as well. So the second trimester uterine artery Doppler is detecting almost 45.5% of the late FGR actually. So that screen is actually also vital. If you are not doing at the fetal echo time or something like that, the uterine artery PI, we are actually escaping that thing. So though it is with the false positive rate with somehow high, but still it is 45%. And we are going to see another is symphysis of fundal height. The NHS London has implemented in their gap study that they are actually stressing on the symphysis fundal height that is detecting almost 60% of these small for gestational age. We are not going to forget our clinical things that we used to do in our bedside actually. And smallness and abnormal Doppler in combining that is detecting almost 74% of the SGA. And when you are calculating with all kinds of maternal characteristics and biometry, Dopplers, everything, then you are going to almost detection rate is so high, it is almost 83%. So that is why we need to go for the everything. Ultrasound in the third trimester is going to detect everything clinical parameter as well as other things. So that we are going to agree with actually. And with the less. Yeah, yeah. Yeah.
One recent guidelines, recent journal, it indicates when there is difference between uterine PI in first trimester, mean PI, and the mean PI in the second trimester. If the difference is more, then the late onset FGR prediction is more. It could be
Wonderful. Yeah,
that is
wonderful to know actually. Yeah. So many things are actually researched and come out with the time actually. So the 36 week scan is going to detection rate is high that Dr. Vijay was telling just now actually, with the false positive rate is also very high. So I would like to ask Dr. Shankar De, what are the diagnostic parameters for the late FGR?
The same thing already defined by you already told by many of us. It is the hemodynamics changes that indicates the possibility of the late FGR. The diagnosis is by that it will occur after 32 weeks definitely, and there will be no congenital anomalies. And when the estimated fetal weight is less than third centile, it automatically goes in favor of FGR, not the SGA1. So then, if the percentile is fetal weight is less than 10 centile, but if it is crossing more than 2 quartile, then also it falls into category of late FGR. Along with the changes in the doctor, like CPR is less than 5th centile or uterine PI less more than 95th centile. So these, especially the doctor one, the CPR one is nowadays is very given very importance because they can easily diagnose or at least indicate that these cases are going to be a problematic one, or that needs some more monitoring and surveillance. And this is the way how we diagnose or indicate that this is a case of late FGR.
Yeah, that's very nicely told. So another study that is by Rizzo et al. That is in it has been published in 2020 actually. It is one of the innovative study that I can go through actually. They have seen umbilical venous blood flow with the ratio with the abdominal circumference, and that is coming out to be more better parameter than the mean uterine PI, than the CPR, and it is giving more better area under curve for the composite abnormal perinatal outcome, that is CAPO. So if it is the adverse perinatal outcome, we can count down by the umbilical venous blood flow with the ratio to abdominal circumference. It is going to have a HABOC result much better than the CPR also. So many researchers are coming up with many kind of good results. So we can also follow up with for our studies. So Dr. Malati, when to deliver a case of late FGR? What is your opinion? Malati ma'am? Malati? Yeah, ma'am.
If it is stage 1, keyword restriction late onset, we can
Yeah,
wait
yeah.
till 37, that's a recent gestation. If the
Uh-huh.
stage 2, where the collapse diaphragm flu, I think ideally it should be delivered at 34 weeks. We don't have to wait till 37. Any
Yeah.
REDF approach, delivering at 30 weeks will get very important. So it doesn't come at a fraction of a late onset as well, because it's generally after 34 weeks. So ideally stage 1 is 37, stage 2 at 34 would be the best time to deliver. And mode of delivery of stage 1, you can have a she can offer some labor very close CPG monitoring. Any Doppler abnormalities, I think stage 2, 3, 4, chemotherapy with C-section. As per the Australian guidelines.
Yeah, thank you. So the late
But
FGR.
one thing we need not forget the maternal conditions. Basically,
Yeah,
if maternal
yes,
condition
yes, yes.
deteriorates or
So,
if you know what,
most
if there is
important
severe
number is better.
hypertension,
Yeah. If you
maternal.
have a severe antibiotic therapy, I think it's better, whether
And
say
whatever
for
it may, yes, to save the mother, we have to do.
for its the first.
As an
That's
obstetrician,
compulsory.
we should
Yeah,
remember.
that's right.
Yes,
So,
ma'am.
that's right.
Yeah. Nicely
Because
told.
the
Very good.
complication of the exams and complications of patient having a fit and all. So always the maternal part should be
Should
done in
be
all.
priority and some priority.
Yeah. Thank you so much. That late FGR is really easy to take the decision for the delivery, but we need to think about the sudden IUDs that can happen. So that's why the screening or diagnosis is more important. Dr. Ananya, can you diagnose this case? Ananya?
So,
Yeah.
yes, ma'am. Yes, ma'am.
Yeah,
Just going through the charts.
Yeah.
So, yes, so there is an EFW discordance of 22% between twins A and B. And as I can see, the Doppler is not. So there is an absence of endoscopic flow. Is it an absence of endoscopic flow?
It's a reversal of the endoscopic flow in the twin
That's a
A.
reversal of endoscopic flow. So
Yeah.
yes, so this will be a case of type 2 selective fetal growth restriction.
Yeah, very good. How you are going to differentiate between a TTTS and selective fetal growth restriction?
So one of the things is the Leica discrepancies will be there in case TTTS.
Hello?
Oh, am I audible?
Yeah, right now you are audible.
Yeah. So there are definite diagnostic criteria for TTTS where we take into account the Leica pockets also, which will not be valid in case of the SFGR, where we are mostly concentrating on the group discordance between the two twins in terms of AFW discordance.
And about the most striking is about the bladder basically. Both will have the good bladder basically. The TTTS will have the criteria of a small bladder and a large bladder basically. And with all kinds of Doppler criteria that you have told very nicely. And these are the things we can see in ancillary the umbilical reversals and with the B with the normal umbilical actually. Yeah, so these are the things. So this was the heart with the heart A and heart B. That was a stressed heart with the more intravascular thickening and as well as the ventricular wall thickenings. All these things we can see in the heart A, which is a selective fetal growth restriction. So, Josna ma'am, can you tell the selective FGR twins the clinical criteria that we have already diagnosed, but we want to stress in on the clinical criteria in a very solidified way.
So, again, as per Delphi consensus, the criteria for diagnostic criteria for selective fetal growth restriction is different for the dichorionic twin and the monochorionic twin. For the dichorionic twin, the solitary criteria, that is a must. It is effective fetal weight less than third centile. And the contributory criteria is 2 out of 3. What are those 3? The effective fetal weight should be less than 10 centile, or there is twin to twin discordance of more than or equal to 25%, or there is umbilical PI more than 95th centile. So any 2 out of these 3, along with if there is EFW less than third centile, that is the solitary criteria. If otherwise, you can take 2 out of 3 to diagnose a dichorionic twin to be a selective growth restriction. Taken for monochorionic twin, the same thing, except we have to add the abdominal circumference less than 10 centile and take all these 4 into consideration. Effective fetal weight less than 10 centile, twin to twin discordance more than or equal to 25%, umbilical PI more than 95th centile. Only thing we can add is the AC less than 10 centile, and any out of 2 out of these 4, if it is there, then you can diagnose it as selective fetal growth restriction.
Yeah, thank you so much. Malati ma'am, how to monitor this growth of the twins? Can we enlighten us?
First we have to see what type of twin, whether monochronic or dichromatic. All monochronic twins have to be monitored every 2 weeks. till delivery. All DC gateways have to be monitored every 4 weeks. So once you have found the select.
Malati ma'am? Ma'am?
Can you hear me?
Yeah, right now we can hear you.
Yeah. Yeah. So if it is, type 1 selective growth restriction, the patient we need to monitor the doctor annually regular every week and the growth every 2 weeks and consider delivery at 36 to 37. Okay. This is the TC treatment. If it's a type 2 where you have an abscess or intermittent reverse diaphragm nose, we can follow up the fetus every 3 days with the Doppler and LiDAR and growth every 2 weeks and deliver at 34 weeks of gestation. And type 3, of course, based on Duffield syndrome to decentralized. If it's a monophobic twins, if you find a discordant piece, more than 25%, then you find doctor abnormalities, the idea is to deliver at 34 weeks of pregnancy. But ideally, all MCT every 2 weeks, starting from 16 weeks to exclude, monitor for dispute, monitor for FFPR. All DC treatments monitor every 4 weeks till about 37 weeks of gestation.
Thank you. So it is not so complicating the things, the twins pregnancy about the monitoring of the growth. It is only the regulation, strict regulation we have to adapt in our day-to-day ultrasound. That is only going to make the differentiate. Dr. Sujit, I want to ask you how intrauterine growth restriction, whether we can at all prevent it?
Yeah, in some way we can prevent it because you have to identify the high risk cases with maternal characteristics, blood pressure monitoring, increased uterine artery pI more than 8 percentile. You can add low dose aspirin 150 milligram HS for those patients, and in a good number of cases we can prevent FGR. But besides this, there is no other way to prevent FGR. You can just only keep on watching, put them under strict surveillance, good surveillance, and diagnose FGR on correct way and manage according to the Barcelona protocol. This is the only thing we
And also,
can
we
do.
should take care of nutrition. Maternal nutrition has also become one
That's
of
a
the
very good
reasons.
point actually I want to
Yeah.
stress. Really, absolutely.
Actually, yes, one thing, if you look for the cause, the root cause is a genetic one, the interplay of environmental and the genetic components. Now, the epigenetics also has been implicated in all those things. We cannot reverse or we cannot prevent in that way, basically. It's the genetic potential of that fetus that couldn't grow because of some reason. And that reason is largely unknown till now. And we have the final pathophysiology is the placental pathophysiology that can only be the possibility of the preeclampsia or eclampsia that can be reduced by the introduction of aspirin 150 milligram bedtime, but not it cannot reverse the process of FGR. That is not actually
Yeah, but
I mean
preconception
not
counseling is also very important. Like preconception counseling,
yes.
patients have high BMI, obesity, or is nutritionally malnourished. So these two can also be taken care of. Yeah, the patients who are nutritionally deficient also tends to develop.
Definitely, ma'am. Those things are always there. Yes.
Anything want to more add to Dr. Sankardev? You want to add more?
Actually, for the late age here, the confusion is that we cannot measure the severity. Just like in the early onset, the cascade of events is there in the first, early onset one. But for the late onset one, we don't have that much of parameter to understand it's going to be a bad one. It can deteriorate suddenly like that. The severity progression is not optimal monitoring thing or the optimal timing of delivery. These things are evolving. These are not practically very much of a strong evidence based right now. The research is going on. It's not that you can tell the severity for a late age.
Yeah, that's true. We cannot prevent that. So, can we add on to this thing? Can I ask all the panelists how common you are inculcating this serum biomarkers in your day-to-day practice for predicting the IUGR or preeclampsia like PAIGF, SLPT1? How common you are doing that?
Ma'am, combined screening we definitely do, Papa. So that also we take into account. And PLGF, we are trying to advise all patients and counsel that is important. And we definitely at our institute, we are doing PLGF also. But we don't do
That's right.
SLFT. Yeah.
PLGF is one of the most good predicting factor actually. That has got a most good. PAPE has got a less association with the preeclampsia. It has been already been shown, and PIGF is the one of the very good association. Almost 88 percentage association with the PIH or
Yes,
FGF.
Josmina.
Haha.
Yes, Josmina.
Yeah.
Actually, what happened, if we use the SFLT and the PLGF as a ratio, then the detection rate of possibility of preeclampsia in a short term period, it's enhanced. And nowadays, it's been used widely.
For SLFT, it becomes late. Actually, PLGF, we are doing it at the first trimester screening, combined screen time. But for that, and we can incorporate aspirin very early. So I think at least we should go for PLGF, and it is reasonably not very expensive. With a combined screening to add PLGF, the rate is not very high. Just 200-300 rupees more. If you counsel the patient, they definitely agree to it.
Yeah, that's
So-
great.
I think the patient generally agree to do the PLGF in the first trimester, but when you ask for a flit in the second and third trimester, they don't do it. Because the cost issue cost somewhere around 3,000 rupees.
Yes,
in
yes.
Tamil Nadu. I know
Actually, the intravenous PI is doing very well in the first
Yeah, that's a
trimester
predictor.
in the FTS scans. During the FTS, the first year screening, we do the NT and then the intravenous PI. That will tell you when to, I mean,
What are the information?
how
No.
to.
Actually, we have to put everything into FMF calculator. Basically, FMF calculator, if we are
PLGF
not
is
having
there.
PLGF,
Yes,
we
yes.
use PAPA. But if we have PLGF, we'll have better sensitivity rather.
Better outcome sensitivity increases, but not very much. 7% increase in sensitivity.
So my patients, when they prefer to do NIPT instead of double marker, so some patients they prefer to do NIPT instead of double marker in the first trimester. There I advise to give the PLGF as well with that same package because NIPT cannot predict your preeclampsia, which is the most deadest killer in our scenario.
Preeclampsia is more prevalent than aneuploidy, so we should definitely not ignore preeclampsia.
Yeah, that's true. That's true. That's a really nice discussion we end up with actually. Yeah. So, Dr. Megha, what are the points of counseling? How you're going to counsel? I'll ask all the panelists to put their efforts for the counseling as well. So what are your points? Please be prepared to answer. Dr. Megha, please let me know.
I think Dr. Megha is left. She had her issues for the connectivity.
Okay. So please, all the panelists, count down with one point for the counseling. When we are getting any
I think,
IV patients or something.
Once you diagnose people with restriction, they will stage it important to talk to the patient. It should be multidisciplinary. It should have an hematologist in hand, and then how long the baby needs to be in NICU, what are going to be the long-term implications, short-term implications will be discussed in detail with our perinatal team of the neonatologist, pediatrician, and the counselor together at least the first sitting. And every sitting, of course, we go to it. So that counseling part is very important because if you have one kid baby at the end of the day, you have to spend 50 lakhs to bring the baby alive and what are the complications. So all that should be informed in detail with either a video counseling or documented notes or documentation notes and you should store it in your case notes. That is very important. Always have the neonatologist in hand and with you whenever you do the first count. Later counseling, of course, very difficult to get for person. So initial counseling is very important.
Yeah,
that's one thing I want
Just
to say. One thing I want to say, the most difficult counseling is selective fetal growth restriction and to differentiate from TTDS. And even if in selective fetal growth restriction, we are referring to a higher center for laser, but the outcome is quite unpredictable when the selective fetal growth restriction is in true sense. It is not the TTDS. Here the counseling is very difficult, and if it is grade 2 and 3, then that is totally on the baby's parents' decision whether to go for that or not. I think the counseling, everything should be explained. But in our scenario, when there is no good setup for neonatal outcome, it is very difficult to weigh whether to leave the baby or whether to make the baby out. So the decision counseling, whatever you say,
Actually, we should have very low threshold for referring. If you don't have that setup, we should counsel them that we are not able to, will not be able to give outcome because we don't have that neonatal setup. So we should have very low threshold for referring it to the centers where we have well-equipped neonatal ICU. And definitely when once FGR is diagnosed, it is very much dependent on what kind of ICU facility and neutral ICU facilities you have. So we will definitely counsel them that you can very well go there, and you can also talk to the consultants where you are referring and give them the entire details and referral slip so that they are well managed in the other centers.
And another thing, the
One
growth
thing,
chat is available in the all ultrasound machines. There is a growth chat available, and it is requested to all whoever is doing the ultrasound from the starting, let it put in the growth chat so that the next doctor who is going to do it will refer it. That is the one important thing we are lacking, I think.
And also the Dopplers also, that is also very important.
Both and
Reporting
Doppler, I
Dopplers.
think.
Yeah.
Both and Doppler.
is for Doppler, I want to add one thing. The Doppler, when you do it, it is basically very notorious to be, misinterpreted or wrongly presented by the fetus because there is a change in the Doppler parameters when the fetus is moving or the maternal respiration is there or the fetal respiration is there. So overall, we should do it in a fetal quiescence, and we should be able to confirm it within 24 hours. If we find something abnormal, please repeat it within 24 hours to confirm that finding. Otherwise, we are going. It becomes false positive one. Sometimes we have seen like that. Umbilical showing just a reversal like that thing, and after half an hour, after 2 hours, we found that it's just increase in the impedance that the PI is high. Nothing more than that. So we can we should wait for the final answer, and we can wait on we're gonna wait for the delivery of the baby, so we can gain time. And beware of false positive in adopters. They are very notorious, so we have to be very cautious on doing our adopters.
Yeah, absolutely.
This is very important. Very important.
Dr. Ananya,
Then
you
at the same person, you can do the same time, same sitting. Two recording could
Yes,
be so different.
so different.
Especially
So
when
the
the supine
protocols should be keep in mind.
the patient has been lying on for a long time because of supine hypertension, which is very case of reduced diastolic flow, swing increased pain. To let the patient walk and come back, it comes back to normal.
Yeah.
Yes,
Supine
ma'am, right.
hypertension is to be
Ananya,
kept in
you want
mind.
to add
Yes.
some points?
Down.
I think
Please
everyone
see
has covered
day-to-day
everything.
activities.
The most important thing that has been covered is the multidisciplinary approach. We need a good NICU setup, and cost counseling is very, very important, especially the type of patients that we get to see on an everyday basis. So that is very important. And I would like to ask you all about what is your take on SFGR management when you pick it up at earlier weeks of gestation, selective fetal growth restriction cases in monochorionics. This is a query from the junior-most panelist.
For 26 weeks, I think often, especially in a monoclonic when we find it the core 26 weeks. Ideally, I think we should go for corrective each time because I got one of my patients coming and telling me if the case is going for IUD, do you think the baby will develop fetal anemia? And he knew about the fetal neurotonagram requirement after 4 to 5 weeks. So that is the level of education some people have. So we had to add a population for a PFDR so at around 24 weeks. So they didn't want to have a abnormal necrosis or something on neurotonagram. They're very particular on that. So it's important to counsel and accordingly take a call.
The neurodevelopmental outcome of the other baby who is also good, that can be also affected. So that is most important point we have to be.
So depending on the stage, there is almost a 20 to 29% risk of neurological morbidity of the survivors. So this area seems very dicey to me, like how to approach them and how to counsel them.
Very difficult, very difficult.
It is dicey to everyone. It is even to
No, not only difficult, but it's true also. It's true in the sense that how much you do for that particular case, it may end up with the neurodevelopmental disability of both the fetuses. So that thing should be very well communicated, and the parents should understand that before continuing it or before having any procedure on it. So this is quite natural for them that this may happen.
Yes, because by the time we choose the procedure, we choose to do the procedure, maybe already the neurological morbidity has been incurred to
Yes,
some extent.
yes. About knowing that thing, they must do or they must not. It's their choice only.
It's all
You can't read. Yes, it's
Yeah.
all there. You cannot be very, I mean, judgmental on that or directive, non-directive. We should be non-directive
The
in counseling.
late neurodevelopmental delay, that also is a very miserable condition for the parents.
Yeah.
So that is a very miserable. So follow-up is always needed, and counseling is up to the 1 year of the neonatal period, infant period. That is important, and you ask the corresponding pediatrician and have a touch with them, with the patient, and with a good rapport with everybody. That is, I think, the most important conversation and rapport. That is the most important to keep ourselves safe.
Yeah.
Keep
Dr. Binita,
ourselves
are you there? Dr. Binita? Ma'am? Binita, ma'am?
Yes, I'm there, ma'am.
Yeah. You have got any points to tell about the counseling and anything?
Yeah, I just told no, that we should have very low threshold for referring, and we should be very transparent in counseling the patients. Like this is the outcome. This will be the outcome if you go, and we are referring just for your benefit, and if we and what are the prognosis of baby, everything we should very well explain, and the referral will write all the details of what all findings we have, and once we refer, we should also talk to the referring doctor so that she can manage well.
Second. Dr. Sujit, you have got any kind of point? Dr. Sujit? So we are actually in the verge of the ending our panel discussion. So this is all our messages we have already went through. So in concluding the whole thing, I'm really thankful to all the panelists, all the discussants rather, my respected seniors, my friends, all adorable, Dr. Ananya. So all things has to be done in a very vigilant way, rather in a more better way, starting from the biometry, the Doppler, I hope we have all covered the every kind of messages that actually related to the intrauterine growth restrictions. I hope so. We have done it in a more perfect way. So in the Monday morning, everybody will be doing in a more better way. So to conclude, all women should yeah, please.
No, I want to thank you, Devasmita, for your wonderful moderation. It's a wonderful
Yeah,
That is
thanks,
all
man.
only you have told us.
Thanks, Dee. Thanks, Dee.
Yeah, thank you.
Yeah, thank you so much. Thank you.
Thank you. Bye.
The best.
Thank you, ma'am. Thank you much. Wonderful
Thank
learning.
you.
Enjoyed a lot.
Yeah.
And
Thank
all
you,
the
everyone.
panelists are
We
so
had
good.
we had more than 450 live views today.
So
Okay,
good panelists, so good speakers, such a wonderful moderator, and the questions he has done a lot of work, I think. Devasmita, you must have done a lot of work to make
You
this.
people have answered so well actually. That is most important thing. Otherwise the panel cannot go well. I'm sure
Everything
about
is
it.
complementary and supplementary to each other. That's the thing of this.
Yeah.
Yes, ma'am, definitely. We had seen that it was a very engaging discussion on the current topic, and I must say that it was very heartening to know that all our Fitovision webinars, like the current one, and relevant topics were discussed. I'm sure you all will agree to that. And I just want to specially thank the speakers of our first session, also Dr. Pooja, Kanchan sir, Dr. Bijoy, all who elaborated on the nightmares of the third trimester problems actually. So now, to conclude, I just want to thank or give a special mention for our academic partners also, for our academic partners, MFine and even Himanshu, who handled the event throughout in a very refined manner. All our three webinars went off really well. I also want to thank our national coordinators who cooperated with me, like Dr. Niharika ma'am was there, Dr. Prasanna Roy, and co-conveners Dr. Aparna Sharma and our dear strong-willed Sita madam, as always. And to conclude, I really want to invite the convener of our Fitovision webinar series, our own visionary leader, Bhaskar sir. Bhaskar sir, may I call you upon to just conclude, give last few remarks?
You can conclude, Shama. I have already spoken at the start, and I said thank you to all the faculty, and thank you to Niharika and Shama. And I think the attendance shows that the webinar was actually very useful.
Yes. Yes, sir, definitely. All the trimesters were very well covered, the first, second, and the third currently. So, Sita madam.
Thank you.
Thank you so much. And sir's visionary way is going well actually. Thank you so much.
Thank you, sir. Namaste.
Thank you, sir.
Thank you, everyone.
Thank you, sir.
Thank you, sir. Thank you, everyone. A very good night to all of you.
Yeah, very good night to all of you.
Thank you, ma'am. Thank
Nice
you.
to meet
Thank
you
you
all,
so
ma'am.
much.
Yeah.
Thank you.
Recording stopped.